They ended up having to biopsy her, and she actually had pemphigus foliaceus. She was only about 6 months old. This cat here with the hot spot on the chin, this one was one that we knew was non-seasonal. And with that history, we decided after our initial diagnostics to perform a diet trial. And he's actually doing really well on an elimination diet right now. This little kitten you almost don't need any diagnostics for. Signalment, history, pattern distribution. You know you want to look for ringworm. This pup here was a well-controlled allergy atopy dog that all of a sudden started licking and chewing despite being on Apoquil. And we took a look, found these brown lesions on the nails, and did our diagnostics and discovered a yeast pyoderma. This pup here, we didn't actually need any diagnostics. We used our history and our signalment to determine that he had ichthyosis. It was a young golden retriever that had those big scales flakes since birth. All right, so we're going to get into our first diagnostic, which are skin scrapes. Now, I'll admit, I've fallen out of the habit of doing skin scrapes for every case just because of the prevalence of isoxazoline. So I feel we don't see Demodex mites as much, but it is still a very important diagnostic that we should be performing. So you want to make sure to really put that mineral oil on both the blade and the slide. I feel it really helps you get a good sample and helps keep that debris on the slide while you're transferring, or on the blade as you're transferring it to the slide. For those deep skin scrapes, you really want to push that skin, push those mites up to the surface. I was taught to squeeze until you go, so you really want to get in there and squeeze it. Don't be shy. So remember, for those deep skin scrapes, to scrape till you get that capillary bleeding, or else you're just getting a superficial scrape. The other thing I always tell the students is warn the owner that you are going to be doing this skin scrape, and they will look like they have little abrasions on them. Because that's when when you warn that owner that this is going to have a little scrape there, then you get the, oh my gosh, it's a show dog, I don't want you to scrape it, or so you want to warn them so they're not surprised. You really want to lower that condenser down. You can see here in this picture with the condenser up versus condenser down. It really helps highlight those mites so you can see them better. Some pitfalls I see with skin scrapes are assuming that the superficial skin scrape will rule out scabies. So a pintle petal reflex is actually more sensitive for scabies than a skin scrape. Scabies mites can be so hard to find on a regular skin scrape. So for a pintle petal reflex, you can just grasp the ear and then rub it vigorously for 5 to 10 seconds, and that back leg should come up and they should start trying to scratch their head. And that would be a positive pintle petal reflex. I don't know about you, but I really don't like trying to put a blade near a wiggly puppy's eyeball. I don't want to be having to send to optho to do an enucleation because I've ruptured their eye. So I prefer to do hair plucks for that in that area. So very simple, just you grab your hemostats, a clean pair of hemostats, grab that hair around the lesion, place it on a slide with a little mineral oil, drop your condenser down and look at it just like you would a superficial skin scrape. Tape preps I recently learned about in the last few years, and I really like them. You can tape just your clear tape and press it onto your area of interest, so your hair loss. You're going to press that tape down, squeeze that skin, squeeze those mites right up onto the tape, and you can take that tape directly, put it sticky side down on the slide, drop your condenser down, and take a look for those mites. And that way you also don't have to worry about causing an abrasion on the skin with either of those options. Don't forget, in cats, you can often find the Demodex mites on fecal sample as well, as they ingest those mites as they're grooming. Next up, we're going to talk about cytology. So for the students, I tell them, do the cytology. Nothing makes me more sad when I see an ER report from one of my patients, came in for something, ears or whatnot, and they didn't do a cytology. And I'm like, oh, what was in there, right? You really want to get that baseline cytology each time. You want to know what you're dealing with. That way, if you send home antibiotics, you think, oh, it looks like a bacterial pyoderma and it's not getting better, and you do the cytology, it turns out it was yeast the whole time. So we really want to know what we're dealing with before we start treating. Cotton tip applicators are really great for getting in those hard to reach areas, those nasal folds of those bulldogs, between the toes, or other tight spots like at the base of the tail. And those you just roll up in there and that your area of interest, and then roll it onto your slide and stain as normal. Toothpicks are really great for getting that sample from the claw folds. And if you don't have the toothpicks, Usually what I'll do is I'll take these cotton tip applicators, the wooden ends, and I'll break them, and I'll use that to get my sample. Just scrape the debris from around the claw fold and put that on the slide. And then you can just stain it in Diff Quick like normal. And you'd be surprised how much yeast or bacteria you can get from just a little bit of debris from those nail folds. It's shocking sometimes. Some things we want to avoid. We don't want to rely solely on the appearance or smell of the lesion to determine what it is. We all walked by that dog and said, that's yeast, right? But maybe they have a bacterial component in there as well. Or maybe it truly is just bacteria. You don't know until you look. You really want to make sure you're wearing gloves. We don't want to sample our own flora when we're getting cytology. There's also quite a few zoonotic diseases that have skin presentations that we don't want to take home. There's also quite a few methicillin-resistant bacteria around that we do not, or multi-drug resistant bacteria that we also don't want to get on ourselves. We really want to make sure we're sampling intact pustules and under crust. Those are a treasure trove of information. You find an intact pustule, it's like Christmas. Like, you really want to sample that. And to get those are very nice. You can use a sterile needle to poke it and put it directly on the slide. Or you can do it the lazy way, which is my way, and take the edge of the slide, rupture the pustule, and then use that directly. You can also use the edge of that slide to lift up underneath that crust and get a good impression smear under there. You get so much information rather than just putting it on top of the crust. Be sure to get underneath that crust. Tape prep is another way you can do cytology. These are really great for dry lesions. So if you got that nasal fold and it's really dry, but it's really red, and you roll your slide and you're like, oh, I'm not getting a whole lot, go back in there with some tape. So make sure you're using transparent tape. The frosted tape you're not going to be able to see through. I usually like to take off that little bit that's hanging there and take that part off first, and then you get a fresh piece before I start my sampling. And then with the tape, you can also use that in conjunction with a superficial skin scrape to look for things like Chlamydia or lice as well. They'll just stick right on that tape. You want to be sure that you do not use the fixative jar if you're using tape. That'll mess up your sample, it'll mess up the tape, and your sample will not be visible. It can be a little more difficult to see through those tape preps. It picks up a lot more debris, so there's a little bit more of a learning curve with them. So you may have to go up and down with your fine focus to get through multiple layers of debris. And I cannot tell you how many pieces of tape I have lost in the stain jars. So what I found works best for me is to take the slide, put the sticky side here, wrap it around, put the sticky side on the other bottom, and then to stain it in the second and third jars. Dry it off a little bit, place the tape directly onto the slide. It acts as its own cover slip. Some people do like to just dunk it in the third jar, or some people do like to take a couple of drops from the third jar, put it on the slide itself, and then put the tape directly on top. Whichever way works best for you, as long as you're not using the fixative. Cases of mistaken identity. So these are things that pop up on cytology that the students are always questioning me on. So one of the big ones is Conchiformibius or Simonsiella. These are very large bacteria, bigger than the normal rods and cocci that we see. And these are just normal oral pharyngeal bacteria. They're not pathogenic. You don't need to treat them. They're not going to do anything. What they do tell you, though, is that patient has been licking that area. So if the owner says, oh, I've never seen him lick, they're not doing any licking, and you do cytology and you see these and you're like, yeah, they're licking, right? They're definitely there. They're definitely going after it. Melanin granules can be mistaken for bacteria. These are usually smaller than cocci. They can stain this kind of brown color, or sometimes they'll stain a little more purple. They're always involved with a skin cell, little keratinocyte here. They're never free floating on the slide. Remember, darker pigmented dogs are more likely to see more of these as they have more pigment. Stain precipitate, I see this one quite a bit. Just a few weeks ago on junior surgery, they had stained their slide. They hadn't dried it very well. They let it dry flat, and their stain precipitate kind of dried all over the slide. And they came to me and they said, well, the dog's got too numerous to count cocci. So I said, oh, I want to see. So I took the slide and I was like, oh, guys, I'm so sorry. That's just stain precipitate. You really got to, dry your slide at a slant or make sure you dry it well. and make sure you're looking for fully formed round bacteria versus this kind of amorphous debris. Other things that may show up on a tape prep or a skin scrape would be fabric fibers. These are not parasites. Pollen or mold can also be mistaken for parasites or abnormal cells. So dermatophytosis, or ringworm. We really got to make sure to hold that wood lamp in the dark room close to the skin. I know nobody wants to catch ringworm, and they kind of want to do it from a distance, but you really have to be pretty close, within a few inches. Depending on the lamp you're using, you may need to allow time for that lamp to fully warm up before you use. And you should allow yourself probably about a good 5 minutes at minimum to scan the animal to make sure that your eyes adjust to the dark, and that if you have anything slow to fluoresce, that it will show up better. Remember, we're looking for that green color that are on the hair shafts. Now, say you're presenting an animal with no lesions. You're presented with a beautiful long-haired cat. The client comes in and says, my doc told me my cat gave me ringworm, and I want it tested. And you look this cat over, and there's absolutely nothing. It's absolutely gorgeous. You can use what's called the Mackenzie toothbrush technique. So we have these nice individually wrapped toothbrushes, and you can get them in bulk, or you can get them from the dollar store. You're just going to rub that cat all over with the toothbrush for about 3-5 minutes, and most cats really enjoy it. They like it. And here we'll just submit the whole toothbrush in the envelope there to the diagnostic lab for plating. If you're doing it in-house, you can just take the toothbrush directly and put it on your dermatophyte test media and get the hair from there. You really want to make sure that you're checking those plates every day when you're running them in-house. The color change and the colony growth should occur at the exact same time. If you get colony growth and then you have color change a few days later, you most likely have a contaminant. An easy way, or quick way, to check for dermatophytes in clinic as well is to perform a trichogram. So pluck some hairs from the periphery of the lesions, or if you have any hairs that glow on wood lamp, make sure you collect those and look at them underneath the microscope. You can either put them in mineral oil and cover slip, because you usually need to go to 40. I don't use KOH that much. You can use KOH. One of my coworkers likes to stain hers and look at them that way. And you're looking for the little arthrospores on the outside of the hair shafts, disrupting the hair shaft. And that's kind of what they look like on a stained version as well. And this does take a little bit of practice. They can sometimes be tricky and hard to see. If you have animals that have color dilution, they may have melanin clumping in their hair shaft, so it may look a little odd. So you have to make sure, if you have like a, what are those things that look like Weihenreimers that are not silver labs, they may have something like that that you can confuse with dermatophyte. Some pitfalls I see: not everything that glows is ringworm. Remember, only Microsporum canis will glow, and depending on which source you read, most of it glows, or about 50% of it glows, depending on which study you look at. So you can have false positives due to scale, blood, crust, or certain medications. We get a lot of little orphan kittens that have ocular herpes and they're on eye medications, and we go to wood lamp them and their eyes start glowing the different colors, the fur around there. If I'm ever uncertain if it's medication or if it's plastered on food or anything like that, I'll just take a damp cloth, wipe the area gently, and refluoresce. If it's ringworm, it will still glow. If it was anything else, that color should have faded. We really want to make sure, if you're performing in-house fungal testing, that you also take a look at the cytology of the colony that you're growing to confirm the species, and we'll go over that on the next slide. So we want to make sure we know what we're dealing with. Ringworm PCR is not as helpful for determining a mycological cure because it is getting amplifying DNA that is present. So even if the dermatophyte is dead, it will still pick it up as that it's there. So if you are testing an animal that's in the process of being treated, you probably should stick with a fungal culture or perform both simultaneously so that you're not getting any false positives. So how do we tell those apart? So Microsporum canis does have macroconidia, and this is the forms that you'll see on the plates, not on the animal. Macroconidia with 6 to 15 cells. They have the thicker walled cells, so thicker septae with a terminal knob. Nenesia gypsiae, formerly Microsporum gypsium, so I will forever in my brain be Microsporum gypsium, but the name did change. Has fewer cells, thinner walls, and is more ellipsoidal in shape. Trichophyton microphytes is a soil-based, and it is, I think, the coolest looking one. His micro and macroconidia with chlamydia spores and fungal and spiral hyphae. So dioscopy, I feel, is an underutilized diagnostic. It is used to differentiate between erythema and hemorrhage. So a positive dioscopy is where the skin should blanch. So you press the slide on the chin here, it turns the white color as the blood flows away, and then as you remove the slide, it should go back to the normal pink color. So that is the expected response. So that indicates a vascular vasodilation or inflammation. Blood is in the vessels. Negative dioscopy, or no blanching, that is not what is expected. So that indicates hemorrhage. So the blood is not in the blood vessels anymore. And you can see this with cutaneous adverse drug reactions, coagulation issues, epitheliotropic T-cell lymphoma, vasculitis, and erythema multiforme. So if you ever have a patient and you're like, oh, is this a macular papular rash or is this petechia? You can perform dioscopy and see if those lesions blanch. If they blanch, you're golden. If they don't blanch, then you got to start looking for reasons of why we have this hemorrhage in that area. Ear cytologies. This is something that I have learned through many errors to break my left Q-tip to remember which ear is which. So the second I swab the ear, I break that left Q-tip. I have a really bad habit of starting to talk with owners, and I have the swabs in my hands, and then by the time I go turn to get my slide or go to the other room to get a slide, I've forgotten which ear is which. So if I break my left Q-tip, I know that I've always got that left ear. I like to also roll my left ear swab into the shape of an L on the slide near the frosted side, so I consistently know which side is up, which side is the left ear, and there's no questions. I had a case on junior surgery a few weeks ago where they broke their left Q-tip, they swabbed it, but they put the left on the right side and the right side ear on the left side and didn't do the L's, and they didn't label it for me. And then when I said, okay, I see this amount of bacteria in this ear and this amount of bacteria in that ear, and they said, well, I got the opposite. And I said, okay. And then they went back and talked with their teammates and decided that they had done the cytology the opposite way. So if you're not the one rolling your slide, making your slide, it helps create consistency. Heat fix, I don't heat fix my slides anymore. You can still do it. I found it saved me a little time, and I didn't see any decrease in the amount of bacteria or yeast I was getting, so I just dropped heat fixing completely. We want to make sure that we check an ear cytology each time. We don't want to assume that because they always have yeast, that is yeast again. Sometimes you have different organisms. Like I said, we want to know what we're dealing with before we start treating. If I'm seeing rods on cytology, that's going to change my medication choice. If I'm seeing just yeast, that may change my medication choice. There's so many products out there that are combination products, but there are newer products out there that are solely anti-inflammatory and antifungal. So we want to make sure that we're covering all of the organisms that are present. We want to make sure that we check the status of the eardrum. This will also change my medication options. If I am going between a leave-in product or a daily product, if I can see the eardrum, I'll probably choose the leave-in product. If I can't, I'll use the topical product that I know is safe if I can't see the eardrum. Now, there are some times when there's so much stuff in there, it requires multiple cleanings to get down in there. Or maybe some patients just are not tolerant of an ear exam. I get that, it happens, but do your best to try and check that eardrum every time. So moving on to cultures. So things that can indicate that you need a culture include seeing rods. It just looks odd. It just does not look like a normal pyoderma. If you have cases of treatment failure, you suspect a methicillin-resistant Staph pseudointermedius or Staph aureus, or if you have a really deep infection. Those would be all indications that you should perform a culture. You can collect the sample from the intact pustules. So like this little pustule right here would be perfect. Again, just rupture it, collect your sample and send it in. Under crust or under collarettes are also really nice places for collecting samples. If you use a moistened swab, you can get a better sample collection for some of these drier lesions, especially if you don't have any intact pustules. Draining tracts are also a great spot for collecting samples. If you have deep infections, maybe you have like a nodular pyoderma, you may need a biopsy to get for a deep culture. So some culture pitfalls. We really want to make sure we're checking cytology first. There are sterile nodular dermatitis, and there are times when we may have an autoimmune condition and we're not seeing bacteria yet. So we want to make sure that if we're going to spend the money on a culture, that there's actually bacteria there to culture. We want to make sure that we're extruding that pus from that draining tract. If you cannot put the swab into the draining tract to collect the sample, then I would say wipe the site gently and then exude that pus and get the pus from deeper down in there. Really squeeze, get that pus out. So you're getting a representative sample of that deep material. What about ear cultures? Well, ear cultures are actually quite controversial, believe it or not, with some people doing them a lot, some people not performing them at all, and some people being somewhere in the middle. If for your routine otitis externa, most people probably wouldn't culture that. If you're concerned about an otitis media, that's when a lot more people are more inclined to perform a culture. Now, if that eardrum is ruptured, you can go down there and get a sample directly, but some animals will regrow that eardrum and you have to do a myringotomy to get your sample. And they've actually found that you can get different bacteria if you culture the middle ear versus the external ear canal with some of these infections as well. So if you're gonna go do an otitis media and you're going to collect that sample from the middle ear, be sure to collect a separate sample from the external ear canal as well. If you have chronic ear infections that are just not getting better, that would also be an indication to perform a culture to see what you're dealing with, to see if you have a multi-drug resistant bacteria or if you have some other type of multiple combinations of bacteria in there. If you're using oral medications, that would be another indication for culture. You want to make sure you're getting the right antibiotic for that organism. Remember that MIC and on the susceptibility panels are based on serum drug concentrations, not on topical applications. So if you have a bacteria and you get your susceptibility back and it's just resistant all down the line, keep in mind that if you're giving that medication topically, you're bathing that bacteria in that medication, some of those resistant antibiotics may actually work for you, depending on the bacteria and the antibiotic. So don't be shy. Reach out to your pharmacologist, reach out to your dermatologist if you have any questions. So fine needle aspirates. I love teaching the students how to do these. They're always so shy about it. I'm like, you really got to get in there and poke them, right? But they don't like to have all their slides ready and supplies ready. So I tell them, make sure you get your tray, all your slides you need, have the box of slides handy in case you need more. Get everything ready before you get rolling. Make sure you have gauze or a paper towel handy. Sometimes these do bleed after you poke them. So you want to make sure you have that handy so you're not running across the room to go grab something as the animal's dripping blood on the floor. I always want to warn owners of potential for a non-diagnostic sample. We all have those times where we aspirate it and we aspirate it and we aspirate it and we're not getting anything. So I usually tell people I have about a 70% chance of giving you an answer on the spinal aspirate, but there are times when those cells just don't like to be apart from their friends and we may not get an answer and you may have to move on to biopsy. Be sure to sample multiple sections of larger masses. You can have mast cell tumors that hide in the middle of lipomas or other masses hiding in there in between lipomas. So we want to make sure that we're getting a representative sample. Or if you have an area that's maybe necrotic, maybe you hit a necrotic area and you don't get a good sample, but over on the other section of the mass it's not necrotic, so you have a better chance of getting an answer. Make sure you're always checking a slide before you send it in. I do not stain my best slide. I stain one kind of in the middle towards the bottom end of what I think looks good on the slide to make sure that I have cells on there. There's nothing worse than spending the client's money only to be told non-diagnostic, not enough cells, right? So make sure you stain at least one slide to make sure that you have something on there. Do not send all of your slides stained. Make sure to send your best slides unstained, as they do use a different stain over in the lab. I think it's a modified right stain, instead of a diff quick. Don't rely just on the feel of the mass or the appearance of the sample on the slide for a diagnosis. Even if I think it's a lipoma, feels like a lipoma, moves like a lipoma, sprays out like a lipoma, I still do stain it to make sure I don't have any hidden cells in there that I'm missing. We always want to measure it before we get that final aspirate. Sometimes you have that cyst and you get that really satisfying, it squirts right back out at you, and then it deflates, so you can't measure it. So I do have the students measure in 3 directions, length, width, and height, before we FNA it. I've also seen mast cell tumors. How many of you guys have seen the mast cell tumors swell before your eyes after you poke them? And then you know what they are. Right. So to biopsy or not to biopsy? So things that would lean you more towards biopsy. So a dermatosis that is not responding to your first-line therapy. If you have persistent ulcers or vesicles. If you have an unusual or severe appearing dermatitis, like the dog with the pemphigus foliaceus, I was like, that is beyond a puppy pyoderma, right? That was beyond what I would expect. If you have suspected neoplasia. And before you want to start any dangerous, expensive, or time-consuming therapies, that would also be an indication to biopsy to make sure you're on the right track. If you have something that you're like, oh, it's a poodle, it's kind of scaly, it's losing its fur a little bit, and you're like, oh, that's going to be sebaceous adenitis. If you have something like that, you want to confirm something that has a pathognomonic appearance, that would be also an indication to biopsy. Biopsy is most reliable for cancers, autoimmune diseases, some alopecic disorders, and deep infections. It's not as good for allergy or endocrine. I see a lot during dermatopathology rounds. They're like, well, it could be allergy. We've ruled out everything else. So it's a little trickier to diagnose that one definitively. So some biopsy pearls. We really want to make sure that we're sampling sites from various stages of maturation in the lesion. So we get maybe this little pustule here, we get this little ulcer here, we get this little crust here, and we want to make sure we label all our sites. Nothing makes the pathologist more angry than not knowing where that sample came from. You can do them either in separate biopsy jars or use these little cassettes to help divide them apart. We want to aim for the center of an active lesion and not the edge. The way they prep them in the blocks for the pathologist, there is a chance that you could get normal skin on your section. If you send too much normal skin, they won't have the area of interest. We do not want to prep that skin too much. That's where your answer is, right? You want that crust, you want that top of that skin, so no cleaning it, no scrubbing it. If you have to scissor some of the hair down just a little bit around the site, that's okay, but don't shave it. You're going to shave off all your important information. It's best when the infection is controlled. Deep infections, deep bacterial pyodermis can complicate some of what we're seeing. Mucocutaneous pyoderma and DLE can look similar. So sometimes it comes down to, well, it could be this or this, but I see bacteria, so treat the bacteria and do it again. If you have the crust, send it. That is where your acantholytic cells will be for your pemphigus, and that can be very helpful to the pathologist. Send pictures. They absolutely love pictures. Sometimes things will look fairly boring, quote unquote, on the microscope, but you see the pictures and the lesions are actually fairly dramatic. And so they're like, okay, do I need to recut this? Do I need special stains? Do I need to go back and have them get a different sample, a different area? So these can all be really helpful for your pathologist. You also want to make sure that you give them a history. So the bigger the sample, the better the chances that you're going to get an answer. A minimum of 6 millimeter biopsy punches for most sites, ideally at least 3 samples minimum. There's nothing worse. They'll have a Great Dane with a 2 millimeter biopsy punch, 1, from a widespread condition. And they're like, well, there's nothing on this one. They send me more, right? So they'll go call and say, hey, I need more tissue. We want to send a good history. You will not bias them, I promise you. Send all the history you have. How long it's been going on, what's the lesion distribution, what have you tried, what's worked, what didn't work. That can be really helpful for them as they're going through the differential diagnosis. Sending a good signalment is also very helpful as well. Try not to give steroids right before sampling. If the animal is absolutely miserable without them, then absolutely give them. but you need to let the pathologist know that they're on the steroids, because the steroids can make it more difficult to diagnose some conditions, especially some of the autoimmune conditions. We want to be sure that we're handling our samples gently, that we do not cause any crush artifact with our forceps. So diet trials. So before you pursue a diet trial, you want to make sure you've ruled out all the other common conditions first. You've ruled out fleas, you've ruled out yeast infections, you've ruled out bacterial pyodermas. It's a non-seasonal pruritus before you want to do a diet trial. You want to explain to the owners that it is a diagnostic test. It's a diagnostic test that takes 8 to 12 weeks, and it's one they're going to be doing mostly at home, but it is still a diagnostic test worth doing. You want to make sure that you pick the right time. So around the holidays is probably the worst time to start a diet trial. You've got pets that are boarding, you've got pets that are going to visit family, or families coming to visit them, and they're eating who knows what, right? So maybe after the holidays is a better time to start a diet trial. You got to pick the right client. If you've got the client with the small toddlers in the home that are throwing everything on the floor, it's going to be harder to make sure that you're doing a true diet trial with that pet. If you've also got a client that, for whatever reason, you can't get every client in the home on board with doing the diet trial, that would also be a home that might not be easy to get it done. And you may have to wait. You may have to discuss this with the client multiple times and say, hey, when's a good time? When's everybody's on board? And then we can start this test. Don't be afraid to use antibiotic medication, right? These pets are itching. It takes time for diet to work. So give them their medication, give them their Cyclone, give them their Apoquel, give them their Zenrelia, whatever they're on. And then over time, you can start withdrawing that medication, maybe 4 to 6 weeks in. Start slowly withdrawing that medication and see what the itch level is, right? At the end, and after 8 to 12 weeks, we want to re-challenge with the old diet. It may take a few weeks for the itch to restart. Some people like to do single ingredient challenges, so they'll pick chicken and feed it for 2 weeks. They'll feed beef for 2 weeks and kind of see what that pet reacts to, so they can start picking out maybe an over-the-counter diet or a less prescribed, less limited diet. Now, some pets do so well that the owners are like, we're just going to keep them on the food. And that's fine too. You don't have a definitive answer because you haven't challenged them back, but as long as the pet's doing well, that's what matters. So some pitfalls. So we want to make sure that we're fully covering expectations with owners. In one study, they found that when they did not fully do their client education, they had a 52% failure rate. When they went back and with those clients that they fully explained everything, went through what to expect, they went down to a 27% failure rate. So they halved their failure rate. So we want to make sure that we ask about all medications, foods, supplements, bark boxes, the bologna that they wrap their Apoquel in, anything that goes in that pet's mouth you need to know about. So if they need to keep a piece of paper in the kitchen and every time the pet gets something in their mouth, they write it down for a few weeks, right? That could be really helpful. So sometimes people don't think, like, oh, here's the snack from my chicken sandwich or whatever, and they don't even think about it. So, and make sure you're looking at any medications that they're giving, including flea, tick, and heartworm prevention. So either switching to a topical product or switching to a product that has hydrolyzed protein in it for the duration of the food trial. We want to make sure we're feeding long enough, so a minimum of 8 weeks, sometimes up to 12 weeks. So if you're feeding for like GI stuff, for like diarrhea, 2 to 4 weeks is usually enough, but skin needs 8 to 12. If you have a young growing puppy or kitten, you want to make sure that you're using a food formulated for growth. And we want to make sure that we're not using a blood test in place of a feeding trial. A feeding trial is the gold standard for diagnosing food allergies. Blood tests would look at IgE, which is a shorter half-life, so unless they've eaten that food recently, you may have a false negative. And when they looked at blood test versus feeding trials, there was discordant results, so they didn't get the same answer. It didn't match up. Now, some people do use it kind of as a starting point, maybe, for a diet trial, but it cannot be the only thing that you use to diagnose a food allergy. So the question becomes, hydrolyzed or novel protein? Well, if you know the pet's full diet history, you're more likely to be able to use a novel protein diet. If it's like most of our pets, adopted from the shelter, a couple years old, we don't know what all they've had, you're more likely to probably need a hydrolyzed diet. There can be cross-reaction between similar proteins, so duck and chicken do cross-react, and there's a possible cross-reaction between lamb, venison, and beef. And then the question becomes, do you use prescription or over the counter? Because some of the over counter ones are cheaper. You'll have the client with the cost concerns. But we do want to take into account that there have been studies that shown that over-the-counter diets are cross-contaminated. So they're made on shared lines, so they don't fully clean the lines necessarily between batches. So sometimes when they do the DNA and they look back at what is in that food, they may find DNA of animals that are not listed on the label. So that can derail your diet trial as well. So owner preference. So some owners are just adamantly opposed to a hydrolyzed diet for whatever reason, or adamantly opposed to a novel protein diet for whatever reason. And you got to sit there, listen to their concerns, and see if you can reach a balance. So you can reach a consensus on what you can do for them and their pet that makes them happy and makes you happy. Also, you have to take into account pet preference. So some of these hydrolyzed or novel protein diets do not have a canned version. So if you've got the little dog with very sensitive stomach and only eats the finest Old Roy and canned, then you have to pick one that has a canned option, right? That pet won't eat dry. What about home cooked? Home cooked can be great for the right pet and the right owner. It is time intensive. If you're going to do home cook, it needs to be properly formulated by a veterinary nutritionist. And there is a risk for recipe drift. So recipe drift is when over time, the recipe changes little by little. Maybe chicken was on sale this week instead of lamb, or something wasn't in stock at the store, so they make a substitution. And before you know it, the recipe that they're feeding looks entirely different than the one they were given. So we want to make sure that they're periodically checking back, that they're formulating it right, they're putting the right amount in. So these are some of the diets that are formulated for growth in puppies and kittens. There's a canned option for cats down there. They're dry. It's this one. Hills has Derm Complete. Purina has a couple options. Blue Buffalo, Royal Canin. So variety of options. New ones are coming out on the market every day, so make sure you check with your favorite company and see what they have. Next up, we're going to talk about intradermal allergy testing. So I see this a lot on the JSL paperwork. They're itchy. I think it has allergies. They should go to their vet and get an intradermal allergy test, like right off the bat. And I'm like, hold up, right? That is not our first diagnostic. So intradermal allergy testing is a test to guide immunotherapy choices and hyposensitization. If you're not planning on doing hyposensitization, I would say I don't know if it's worth the money to do intradermal allergy testing. It is not used to establish a diagnosis of atopy. Atopy is a diagnosis of exclusion. You have to rule out all other causes of pruritus and food allergy first. We want to make sure that we're doing intradermal allergy testing or sending for intradermal allergy testing during the right season. So some pets flare more in the spring, some flare more in the fall. I would send them during their higher flare seasons. If you have a young dog and you're like, oh, this is going to be an atopy dog, I know it, we want to make sure they go through a full year, a full cycle of seasons before you test. Or if you have a pet that's maybe new to the area, make sure they've been in the area for a full year, exposed to all the antigens before they get tested. We want to make sure we set expectations. About 70% of pets will respond, and it can take up to a full year to see full effect from hyposensitization. We want to avoid ketamine, diazepam, propofol, and acepromazine for sedation. They do have antihistaminic properties that can affect the reaction, so you may have lower your reaction, your swellings here if you're given any of those medications beforehand. Drugs with withdrawal time. So these are a little bit variable between dermatologists, so make sure you speak with the person that you're going to be sending to confirm that this is the list they follow. But on the whole, most people withdraw antihistamines for about 2 weeks. They will pull oral glucocorticoids for 3 to 4 weeks, injectables for 4 to 12 weeks, and anything topical that goes in the eyes or the ears for 4 weeks. Now, you really got to talk with your client, because how many of your clients have that bottle of Positex in the cabinet, and the second it looks a little red, they just throw it on there, right? So we want to make sure we tell them, hey, before you put anything on your pet, call me, right? Let me know what you are putting on there so we can be sure that that's not going to mess up this appointment you have set up. Some people choose to withdraw oral fatty acid supplements or diets high in fatty acids for 2 weeks. Apoquel, Cytopoint, Atopica, and probably by default Zenrelia do not have a label withdrawal time. Now, That being said, some people choose not to give Apoquel the day of or for a little bit beforehand. Some people prefer Cytopoint not to be given within the previous week or within the previous 3 to 4 weeks. So really check with the person doing your dermal allergy testing what they prefer, because it will vary. Serum allergy testing. These ones you can keep in-house, right? Very nice, revenue generator. Make sure you research the company that you're using. They have repeatable results and good quality control. There was a study a few years back where a company said, hey, I can take saliva samples, and I can take fur samples, and I can tell you what your pet's allergic to. And somebody said, cool. And they said, let me send you some fake stuffed animal fur and some tap water, and not telling you what it is. And they got back allergy profiles for that fake stuffed animal and that tap water. So that company needed a little bit more work on their process, right? We want to test during the right season. So it is recommended to pull that blood late in the allergy season and or within about a month after to make sure that you have those right circulating IgE levels. Make sure you follow your lab's handling and submission protocols. If they want it frozen or refrigerated or however they like it, make sure that's the protocol that you're using. We want to make sure that we're not using serum allergy testing solely in place of a diet elimination trial. Elimination trials are gold standard. Maybe someday we'll get there and we can use a serum allergy testing, but it's not there right now. And then make sure you check with your lab as some of the requirements may differ. So drug withdrawal times for serum allergy testing. So antihistamines, basically everything has no withdrawal time. You can give everything right up to the time of. Now, a little asterisk in some companies, they have a little asterisk. It says consider withdrawing steroids 4 to 12 weeks prior. If you can do that, great. Apoquel, Cytopoint, same disclaimer. Some companies say they're fine, but maybe consider withholding it for a little bit beforehand. So double check with your companies, always call them. Things are always changing. Make sure you have the right withdrawal times. So in summary, dermatologic diagnostics are very essential for helping you diagnose your skin disease and guiding your treatment plans. And I hope that you have found a few pearls or maybe remembered some things to avoid when you're doing your diagnostics. And thank you.
Dr. Christina Gentry is a member of the American College of Veterinary Dermatologists and is a clinical assistant professor in dermatology at Texas A&M University, graduating with a DVM in 2012 from Texas A&M, and then completed her dermatology residency at the Veterinary Referral Center in Colorado in 2016, then spending 7 years in a private dermatology practice in Denver and in Houston before returning to Texas A&M in 2023. Dr. Gentry's dermatology interests include feline allergic skin disease, otitis, immune-mediated skin disease, and client education. So please welcome Dr. Gentry.
Thank you. Thanks, y'all. Can you hear me okay? We switched mics. Good? Cool. Well, I'm really excited to be here. This is my first time being in Manhattan, Kansas, since my husband was stationed at Fort Riley. We left this area in around 2016-ish when I was hopping between Denver and Junction City. So it's fun to be back. So this lecture is going to be our introduction to the dermatologic emergency. Our goal is to differentiate things that are routine and not frightening and things that should get your alarm bells raised. And we're going to kind of build upon the material that Dr. Upchurch already talked about on using the basic diagnostics that we do day in and day out to help us make decisions. So no conflicts of interest. So what are we going to do? We are going to evaluate the seriousness of a patient that comes in with dermatologic disease. We're going to review the 3 main causes of folliculitis because that is the most common thing we see in dermatology and is uncommon for that to be a significant health issue. We're going to then discuss why we consider more advanced diagnostics like punch biopsy and culture. And then we're going to review a few immune-mediated and hypersensitivity disorders. So the first question is this an emergency? And one of the reasons I enjoy being a dermatologic is the answer is almost always no, right? That's what I enjoy tremendously. So derm emergencies are rare, but they do exist. In my mind, a derm emergency is a disease where if you do not start appropriate care in 24 to 72 hours, there is a chance of death or at least significant morbidity in an extended hospital stay. Derm urgencies, or things that you should handle in the first week, which covers most of our immune-mediated diseases, as well as some infectious conditions, are things that we need to deal with soon. Those are actually relatively common. But we also have to recognize that clients show up to ER and day practices and referral hospitals for things that are not truly emergent because otitis and dermatitis are scary looking. They can't tell that their dog has liver disease unless they're yellow, right? But they can sure tell their dog is covered in smelly, weird sores, and that can frighten them and cause them to present emergently. And for those of you who do work in ER practice along with GP, I think we know that some clients will come in just today on a Saturday morning because it is more convenient than coming in on Monday. So how do we triage these patients? Well, even though they're here for a derm problem, we still want to start with systemic signs. What we typically ask is, if your pet is unwell today, is that acute or chronic? Any general information, coughing, sneezing, vomiting, diarrhea, appetite, energy level, and particularly for derm disease that presents emergently, any new medications for these conditions, because cutaneous adverse drug reactions are some of the more serious immune-mediated diseases that we deal with. Once we get that information, then we ask about derm lesions. Are they acute or chronic? If the dog's had allergies for 4 years and today it just looks worse and that's why they're coming into the ER, that's a lot less worrisome or exciting than I have never had derm disease in my dog's 8 years of life and now suddenly there's an eruption of sores. We also like to ask about itch and pain level, and we try to distinguish those two. Pain are things like not wanting to put weight on your paw pads, kind of shivering or moving away when you attempt to touch them, versus itch, which is itching, scratching, rubbing, rolling, chewing, corn cobbing. Itch usually goes along with things that are not as emergent, like allergic disease complicated by infection, versus pain is more associated with immune-mediated skin diseases or deep infections. And then, just like with systemic conditions, any new medications that you have put on. So how do we do our derm exam? Well, I do it the same way typically every time, where I start with the front and work my way back. But in a triaging situation where you maybe squeeze this patient in or you're working the ER, I like to get a really good look at the face, because most of our immune-mediated diseases or concerning emergent conditions are going to have some changes to at least one of the facial mucous membranes. So either maybe we'll have the nose being affected, the lip, around the eyes, or the concave surface of the pinna. So even if you have 20 seconds to just scan the dog's face and oral cavity, you are going to have a really good vibe whether or not this is an emergency or not. Then you'll go down the sides of the body, then the limbs, and do the ears at the end. So symmetry is also a very useful thing for dermatologic lesions. When we say symmetry, we're just kind of cutting the dog in half. It doesn't have to be the whole dog. We can only have facial lesions in one half versus the other, okay? Symmetry is much more common in patients that have immune-mediated diseases. This is a patient presenting for acute blindness for uvea dermatologic syndrome, but on the skin lesions of hypopigmentation of both the haired skin and the nasal planum, so already non-haired skin and haired skin affected, you can see that it is symmetrical. It's also common with endocrine disorders and hypersensitivity. But asymmetry means we don't have the same thing on both sides of the body. This is more common with skin disease caused by trauma or with infectious diseases. So in this particular patient, kind of looking at the front view, we have these multiple ulcerative open lesions on one side of the chest and only on one side of the body. Lesion number is the next thing that you want to look at because that really matters. Hotspots are frightening to clients and they're really gooey and they smell and the dog will not leave them alone. But having one large hotspot under your chin that looks erosive is very different than having regionally extensive or diffuse erosive or ulcerative lesions, such as the patient on the bottom image. That patient has the worst of the worst autoimmune diseases of toxic epidermal necrolysis. So then, when we're presented with these patients, the first thing we want to ask ourselves is, do any of these lesions look like they could be consistent with hair follicle diseases? So this is our papules, pustules, crusts, collarettes, scale, alopecia, cast, and excoriations. So many of the things that Dr. Upchurch had mentioned earlier. And if you have any lesions that match this, you want to start with your basic derm toolbox, which is going to be impression cytologies, trichrogram or scrapings, as well as Wood's lamp. Because what are we trying to do? In a case of an emergency, we are trying to rule in or rule out our common conditions. So we are using our cytology to look for single-cell organisms, whether it's bacteria or yeast. We're also trying to get a gauge on the inflammatory cell population that may be there. That might sway us one way or another. And in cases like cutaneous lymphoma, we're looking to see whether or not we pick up neoplastic cells. Our scrapings are used to find our multicellular organisms. So typically, what we do when we see these patients is we say, okay, could this be bacterial pyoderma? Because I want to make it something that is routine. And then I decide if I think it could be pyoderma, which one it would be. Surface pyoderma, or hotspots that we just outpatient treat with antiseptics. Superficial pyoderma, which has those classic folliculitis lesions of the papules, pustules, and crusts that we treat with antiseptics and maybe some antibiotics. Or does it look like it could be deep pyoderma, where you have papules, furuncles, nodules, and draining tracts that require longer course therapy? Superficial pyoderma, I think, is a very common thing to see, right? That is diagnosed by cytology. And if you're wondering why we're going through routine things when this is an emergency talk, well, it's because if we have a good handle on what looks routine, we can easily identify things that are not routine. So in these images, we have patients that have our typical phases of folliculitis, the papules, pustules, and epidermal collarettes. On our patient, that's our little Visla, short-coated pyoderma, may not have the classic folliculitis lesions. They just look alopecic with scale, but it's still pyoderma. Deep pyoderma can certainly look more alarming because the hair follicle has exploded, leading to this nodular effect that tends to drain hemopurulent material. And depending on the location, such as in the paws, these may be draining enough that clients are seeing bloody footprints and then present them to you. Demodex mites are something that surprisingly we still see on an ER basis. Demodex mites are common in all species, in all breeds of dogs, but particularly we see them in our bully breeds as well as Shih Tzus, and we get the greasy seborrheic form for our Westies. So, demodicosis is also a folliculitis and can look very similar to bacterial pyoderma. Dermatophytosis is our last folliculitis. That's the one that looks, I think, least like classic folliculitis. It's typically annular to weird shaped alopecia with scale and erythema. It likes the face and the tail, and it can become generalized. We get the typical forms in these two images, as well as the dome-shaped acute presentation of a fungal carrion that we'll talk about more in the pediatric lecture. But in general, if a patient comes to see you and you think to yourself, this is annular, this looks like folliculitis, I am doing my routine diagnostics and finding a reason for this, those patients should feel well. So if a patient is coming to see you and they are sick and have folliculitis, you can say, that's great, you got folliculitis, but something else is wrong with you. But if they have demodicosis, that is all over their body, and there's draining tracts associated with it, they may feel unwell, and that's pretty reasonable. Dogs with ringworm in general are going to feel fine. So then what do we do when it's not those things? We have done our basic diagnostics. We cannot convince ourselves that it's annular or that it's haired skin only. Okay, so when do I think it's getting weird? When the non-haired skin is involved. We can't have folliculitis if there are no hair follicles. So your nasal planum cannot, by rule, have folliculitis. If the lesions start to get weird shaped, everything that we see routinely is circles, ovals, or kind of ovals and circles mushed together. If we're talking arcs or snake-like lesions or targets, you know you're already in the realm of the weird. Sometimes we'll also get crusting patterns that we want them to be follicular, but they're just not. They're spanning multiple follicles, such as pemphigus. Blisters are never normals. Nodules that are non-follicular are never normal. Or you have eschars, which are hard, dead skin overlaying an ulcer because you acutely lost blood supply. So here's some examples of non-haired lesions. So we have a kitty patient that has lack of normal architecture on the paw pads with scale. That is not normal. You should always have cobblestone appearance. In this dog with discoid lupus erythematosus, we have crusting, erosions, and depigmentation of the nasal planum. Here's some example of some of the weird shapes. These ones I kind of think look like arcs or C shapes. That is not consistent with folliculitis, or they just kind of go all over the place. Another more extreme example where you have almost serpentine-looking lesions where they're snake-like. And in the corner over here, we're starting to form one of those eschars because we've been acutely devitalized. As you kind of heard in the first lecture, dioscopy is really helpful when you're starting to get these weird red shapes, because occasionally the allergic dog may look very, very red, but when you still put the slide on it, it's going to blanch. Versus infiltrative diseases or immune-mediated diseases where there is free blood are not going to. It's not 100% perfect of a test, but if you're doing it and you're convincing yourself that it's not folliculitis and then the dioscopy is non-blanching, you have more evidence to tell your client that this is unusual. So what do we start to do when the lesions are looking weirder? We've already done our basic cytology, scrape, trichogram, and we've not found an answer, or we've moved past some of them because it's on the nose. When you have strange ones, nodules, cysts, blisters, pigmentary abnormalities where we're suddenly becoming pale, ulcerations, or scarring diseases, that's when you move to more advanced diagnostics. So either a punch biopsy, an excisional biopsy, or the fine needle aspirate. And as kind of previously discussed, how we do this is we find a lesion. In this case, it's a potential opportunistic infection nodule. We line our punch biopsy perpendicular to the lesion of interest, and then we turn the punch in only one direction. We do not go back and forth, because if we go back and forth, you really damage the edge of the sample. And these punches are tiny already, and so you can lose half of the quality of your sample by going back and forth. So just pick one direction that you enjoy. Then you lift it up from the edge, again, not trying to crush it. Trim as deep as you can, and then close the circular defect. So with that background in mind, let's move to the things that are the most worrisome. So these are immune-mediated dermatologic emergencies. There's a list. We don't have time to go through the whole list of them, but these include toxic epidermal necrolysis and the slightly less version of that disease called Stevens-Johnson syndrome. These are almost always drug eruptions. We also get drug eruptions that don't look like this. We have Sweets and Wells, which are two infiltrative diseases that look like each other, erythema multiforme, and then vasculitis. So let's start with TEN. This is the disease marked by confluent necrosis. This means that the skin is dying all at the same time. And as I mentioned, is most likely from an adverse drug event. So in these patients, they may start a common medication. It's often things like our cephalosporins or penicillins or even an NSAID. And within a few days, they become unwell and their skin starts to come off. They should have both haired skin and mucous membrane involvement. These patients don't feel well. This is a systemic phenomenon that is presenting in the skin where their body has told their lymphocytes to tell all their keratinocytes to die at the same time. So if all your entire epidermis is dying, that skin, when you touch it, lifts off, leading to an open ulcerated dermis beneath. So these patients should be depressed, anorexic. They should be pain, not itch, but pain again, right? More severe diseases. And they're likely going to be febrile. Unfortunately, blood work is not terribly helpful for these kiddos because they're just generally inflamed. So either they will have a leukocytosis or sometimes a leukopenia later as all the white blood cells have moved into the skin. And they're often rapidly hypoalbuminemic because they truly have extensive loss through the skin, but they also know that albumin is a negative acute phase protein. So here's another example of this. Again, we have widespread ulceration, so no epidermis remains, affecting in this case more haired than non-haired skin. So here's a patient I had when I was in private practice. This was a 4-year-old miniature schnauzer that came in for not wanting to put weight on its feet and kind of shaking. The dog was treated for a presumptive urinary tract infection with amoxicillin clavulanic acid in the preceding week. So a pretty routine situation, right? The dog has a UTI, you provide them an antibiotic, you go about your business. Well, very rarely dogs will have drug reactions, just like people. And in this case, we have a very ulcerative reaction where it looks like the paw pads are literally filleted off the underlying tissue. And often when you get these severe paw pad lesions, I'll get the question of, well, how do we know it's not just like trauma, like dragging injuries or things like that? And I think it's the way I explain it, it's a very clean break. When you have trauma, you should see kind of an edge to the lesion where it gets deeper as the area where they touch the ground more. But in these patients, it's very similar throughout because whatever the body is doing to attack the junctions, it's doing it at the same level throughout, right? We're just clipping little junctions at the same level, and so the skin is equally removed. Not only does this patient have ulceration of the paw pad, which already means you know this is something very concerning, but we have weird shapes of redness that are not associated with hair follicles. We have, although it's hard to see, little blisters along the lip margin, so another lesion that is never normal, blisters in the oral cavity, and we are eroding to ulcerating large section of our limbs. Pemphigus foliaceus can occur as a kind of idiopathic autoimmune disease, but it's also one of the drug reaction patterns. So in these patients, we have pemphigus foliaceus, which is a crusting dermatosis that likes to affect the paw pads and the face, as well as haired skin only. So these patients, again, will present with an acute onset of severe lesions that are more painful than itchy. So what about erythema multiforme? Depending on when you went to school, and this was me too, at one point we considered erythema multiforme just to be a continuum of toxic epidermal necrolysis because both these conditions cause death of your epidermal cells. But as time has gone on, we know that EM now has a different pathogenesis. It can be idiopathic, but it can be drug-induced. And what makes this one special, and I think the path is the most fun for this one, is that instead of sending out a signal to tell your epidermis to die all at once, and then everything is dead and the skin all flops up, in this one, your lymphocytes are actually going directly into your skin and giving little death hugs to individual keratinocytes. And when they give them the hug, they spontaneously die. So the more death hugs you have and the faster that occurs, the more skin death you're going to see. That makes this condition more variable in the level of ulceration of the oral cavity and the weird shapes on the haired skin. Okay? So generally this is going to be an idiopathic condition, but can occur from medications. In humans, it's most commonly viral associated, but we don't see that very often in dogs. And in our older pets, it can be thymoma associated. So if you have concerns of this, it's a good one to get chest x-rays of from the get-go, so you know if it is associated as a perineoplastic syndrome. So how are these kiddos going to present? Well, this is where it gets a little more variable, because if there's not a lot of death hugs, these patients actually come in feeling pretty BAR. Maybe they just don't want to eat as much because they have oral cavity lesions. Or if it's happening very acutely and very severely, they may be depressed, anorexic, and painful, and have fevers. Just like with TEN, the blood work is going to be relatively unhelpful. It just says that they are inflamed, which you could gather from looking at their skin. So here's some more examples of erythema multiforme in a 6-month-old dog. Taking these lesions individually, right, wouldn't be that exciting. We have red pinna, but it doesn't blanch. Okay, so that's getting a little bit weird. Then look at the belly. We've got these target lesions, which maybe if I just had a few of these, I could say, okay, it's just black fly bites and like move on. But now I have that plus the pinna lesions, and the nasal planum is affected, and it's ulcerative. So I can start to make a case for something more unusual if I combine all those signs of non-blanching macules on the pinna, weird shapes on the ventral abdomen, and erosive to ulcerative disease on the nasal planum, even in a dog that was honestly pretty BAR. So what do we do when we have dermatologic emergencies? Because from this you may say, okay, I'm a little more comfortable with the diagnosis, or I can at least say weird shapes, nasal planum, oral cavity, I am alarmed, but I'm not going to have my biopsies plus or minus cultures back for 5 to 7 days. What do I do in the meantime? Well, generally we give supportive care. For dogs that have ulcerative diseases that affect the oral cavity, they are not wanting to eat or drink, and repairing the skin, it takes a ton of energy. So these are animals that need nutrition support from the get-go. We also know that they are very uncomfortable. If my paw pads were falling off instead of my feet, I would want drugs too for that. So our goal is to keep them happy. And you are starting immunosuppressive therapies before you have a definitive diagnosis. And I get that is scary to start maybe 2 mg per kg on dogs with pred that you don't know what the answer is, but there isn't much outside of autoimmune diseases that are going to have a pattern of blisters or ulcerations of non-haired skin. So what about the next two? Okay, well these are 2 conditions. Has anyone actually seen a case of Sweets or Wells that they know of? Maybe we got someone in the back and a person? Yeah, I love it. All right. So sterile neutrophilic dermatitis used to be called Sweet syndrome. That's what we call it. It's the human name for it. And acute eosinophilic dermatitis with edema, that's exhausting, was called Wells syndrome, which is the human term. So if I switch between Sweets or Wells or neutrophilic or eosinophilic, I apologize. So these are overlapping diseases. The general vibe to these is for some reason, your immune system has been triggered to either send out a ton of neutrophils, the neutrophilic one, or a ton of eosinophils, the eosinophilic one, into your skin. And along with that causes severe systemic inflammation. So what we see visually in the skin is going to be non-blanching red weird shapes or diffuse redness that is most often affecting the trunk and maybe edematous, especially with the eosinophilic kind. Why this happens, frankly, most of the time we have no idea. It seems to just come out of the blue. It's idiopathic. We do know that some patients are drug-induced, which is why, again, we ask about a drug history when we see these pets, because if there's anything new, you want to stop it. And occasionally they're vaccine-induced. So with these patients, like erythema multiforme, the degree of general malaise is really variable. You'll have some patients walking in the door and their owners just said, my dog is neon red. And you're gonna have some patients coming in that have not eaten or moved around for 2 or 3 days. What makes these conditions very distinct from the ulcerative ones we talked about before is 1, these don't usually ulcerate badly, and 2, these animals are much more likely to have other organ-specific signs. Most Sweets and Wells dogs will have prodromal or concurrent GI issues, vomiting or diarrhea. Particularly with Sweets, we see it associated with IMPA and sometimes respiratory distress. These patients can develop a sterile vasculopathy of their lungs, needing oxygen support. Blood work, again, may not be as helpful. The one caveat is sometimes Sweets dogs will have neutrophil counts of like 50 to 70,000. So then if you have a dog coming in, it's not been feeling well, it's had a little diarrhea, its skin's pretty red, and you do your regular CBC chem, and it's got 75,000 mature neutrophils, you should start to tell yourself, this makes a really good case for this disease. So what does it look like? This is a patient that we actually had in the TAMU ER probably about 2 months ago. This dog had a very similar history to that. This was a middle-aged, kind of Aussie mixed dog who went to its regular veterinarian because it suddenly looked like it was having a flare of its known allergies. So the veterinarian gave it an antihistamine, reasonably so, an anti-inflammatory dose of steroids, and sent it home. Within 24 hours, the dog started becoming quite lethargic, had 1 or 2 episodes of diarrhea, and ended up at a local ER. And after day or 2 of supportive care, with not seeing any improvement with typical GI supportive care of fluids, antiemetics, not getting any better, skin is also getting worse, ended up at Texas A&M. So in this patient, I think we can all agree that none of these are circular shapes, right? Like, you cannot make that be a circle in your mind. They're like dots to snakes, and they're all different sizes and shapes. That's a big red flag for us. And in this case, it's just very, very red, and none of this would blanch on dioscopy. But it can also look less exciting. This is the same disease, where in this patient, we have a very similar history, not feeling well, GI signs, joint pain, fever, moderate redness that does not blanch, as well as vascular-looking lesions where we're starting to have skin death. So it's those eschars again. But what about wells? Well, it can look near identical, which is why we consider them overlapping conditions. Here's a patient with facial swelling, diffuse redness. Maybe it was dots here once upon a time, but now the whole thing is red. And obviously it is in the hospital because it is not feeling well. So what do we do about these? Well, if we're presented with cases where we have acute onset, severe redness in the skin, weird shapes that don't blanch, and the pet doesn't feel well, again, it is likely that you're dealing with an immune-mediated disease. So we withdraw any new drugs that have been started because we know this can be a drug eruption. We provide them supportive care. Ideally, these pets stay in the hospital if your clinic is set up for that with monitoring, because Sweets dogs can acutely decompensate with respiratory distress. And again, we are starting immunosuppressive steroids now before we have a definitive answer, because if we wait 3 to 5 days, they may have gone into a respiratory crisis by then. So you want to start the steroids early. Additionally, depending on the severity of the patients, we may also start secondary immunosuppressives. Cyclosporin takes a bit longer, but we can start antihistamines for eosinophilic dermatitis so the eosinophils stop degranulating or not as much. And then in some patients, we're also starting to use a little bit of oclacitinib or Apoquel because of its acute onset. So those are all the really bad things. Those are the things that actually call dermatologists into the ER, even in a university setting. But what about the things that are urgent and freak people out, but it's going to be fine? I think these are probably some of my favorite ones. How about this one? Who has seen this one? Some people? Not too many? Okay. So this is eosinophilic folliculitis and furunculosis, and at least in the South, it's really common. This is an atypical reaction to an insect sting. These are patients that chased a bee or a wasp or put their face in an ant nest, and instead of doing the traditional, I've got a few red papules or my face swells up, they will, within 6 to 24 hours, develop a erosive, bloody sore that is just on the bridge of their nose, never touching their nasal planum. So if we're distinguishing between, well, this is weird and worrisome, and is this a true emergency, and we're looking at the face, yes, seeing acute erosive disease of the face is worrisome, but none of the mucous membranes or non-haired skin is involved. So we're much more likely dealing with an inflammatory disease versus an autoimmune one. And this really can come up within a day. So the dog gets bit by a wasp at 10 a.m., they leave for the day, maybe go to church, run some errands, have a girls' lunch, come back in the afternoon, and the dog will in fact look like this. So that's one of the few times where if the owner says, it happened today with skin lesions, it really did. Okay? So what are we seeing in these pets? Well, they have just exudate and erythema from the bridge of their nose, never extending to the actual nose itself. When you do a cytology, because of course we should be doing our derm diagnostics, if you catch them on the first day, you'll probably see eosinophils mixed with neutrophils. But if they don't come in on that Sunday because they're like, well, that's weird, but I'm not coming into the ER, and they show up to you on Monday the next day, the eosinophils may already be gone, and you're only seeing neutrophilic inflammation. So don't let that sway you that it couldn't be this because you're not seeing the eosinophils after the first 12 to 24 hours. They're deeper in the skin. You may not see them on surface cytology. These kiddos also will develop secondary infections after a few days, which is another reason to do your cytology sampling, especially if they're not coming to you as soon as it occurred, because then you must not only address the inflammatory disease, but the secondary infection that they have developed. For these kiddos, I think once you've seen 2 or 3 in practice, you can be pretty good at spotting them, especially after a cytology that shows eosinophils. You don't find Demodex mites. You know they're a dog that likes to chase bees. It makes sense, right? But if you're not sure or the client is concerned, you can biopsy for a definitive diagnosis. Because these are inflammatory and not autoimmune, the dose of prednisone that you have to use isn't quite as high. There would be no harm if you thought, okay, what if it is a derm emergency and I'm going to put them on 2 mg per kg of pred while I wait for my biopsy? Nothing bad's going to happen. That's totally fine. But if you feel confident about this, you can kind of start your drugs in the middle. So around a mg to a mg and a half per kg of steroids. And after 2 to 3 weeks, this will be completely resolved and the dog will go back to living its normal life. Here's another example of the same condition where it's a little less severe. This was one of my repeat offender children who she was getting over 1 episode and then was a bee swallower and swallowed another bee. But you have the same signs. The muzzle is red and crusty and it's very well demarcated, but her nose is still completely normal and hasn't changed at all throughout this. Another one that tends to show up at the ER or with some panicked clients calling you is nasal arteritis of the nasal planum, dermatitis nasal planum, or nasal arteritis. Dogs have really big vessels right in the middle of their nasal philtrum, the vessels that kind of come down your face and kind of move across and end here. And there is a specific autoimmune disease that only likes to target the arterioles right there. But that's a bit of a problem because as the skin starts to go away, it goes from looking normal and black and cobblestone to maybe a little pale, then it looks almost white, then you start to see pink tissue, and by the time it's down to here, where you can see a little red, perfect circle, they may start dripping blood from that area, and occasionally it'll get deep enough that they will be squirting blood, like a little fire hose, out at you and at their client's home, and they will certainly come to the ER for that. This is more common in our giant breed dogs. The original case reports were all in St. Bernards, but we see them in many breeds now. The medium breed that we see it occasionally in is going to be your German short-haired pointers. So if any of these breeds are popular in your area, expect to see this at some point. This is one where I would actually say don't biopsy, because I am a baby. And the idea of biopsying something that is already just frankly hemorrhaging when you go near it, if you go deeper to these arterioles that are already inflamed and do not wish to behave normally, they will bleed extensively after biopsy. So I am A-okay with you making a clinical diagnosis. If everything else in this dog is fine, there's no other lesions, it's just a ulceration right there on the nasal philtrum. The good news is these pets respond really well to anti-inflammatory medications and immune modulators. So tacrolimus topically is the treatment of choice. And you can use prednisone initially at 2 mg per kg to calm it down if it's actively bleeding. What about paniculitis? Paniculitis is this group of diseases. This is not a specific disease. Paniculitis means that the fat is inflamed or infected. Paniculitis comes in the infectious type. That's what we see a lot in Texas, where you get nocardia, actinomyces, opportunistic fungal, mycobacterium, particularly in cats, that slowly progress to one region of the body, one limb, one side of the chest, and move over time. Versus you can get the autoimmune disease form that was much more common when I lived in Colorado, where the dog is fine one day and within a week has 5 to 6 large fluctuant nodules that when you aspirate them and look at the cytology are pyogranulomatous, and they are febrile. So steronodular paniculitis is the more emergent of the two, the autoimmune disease form, and it can look honestly wild. So those are my fingers for reference. So we're saying that these are holes that acutely erupted within a week, where I can stick 2 or 3 fingers in down to the fascia, or if I kind of look, I can see the muscles below. So these are very deep lesions. And I think it's hard to wrap your mind around that something that looks that awful could be your immune system and not an infectious disease. So my kind of guidelines for those, as I mentioned, is if it is in one region and slowly progressive, the odds are in your favor it's infectious, and you should not only biopsy, but to submit tissue cultures for mycobacterial, fungal, and atypical bacteria. However, if the dog was fine on Monday and by Saturday it's covered in oozing bleeding nodules, it is much more likely that that is the autoimmune disease form. And in those patients, you're kind of going to have to make a case-by-case decision to decide whether or not you are comfortable starting a corticosteroid, not having those cultures back. And that's partially depending on what you see in your region. If you guys tell me, we never see those weird infections you mentioned, well, then you're probably only going to be seeing sterile disease, and that's good. You can start steroids. If you're in Texas like I am, where we see a mixed bag, it's kind of sometimes a hard sell to start steroids while we're waiting for biopsy and culture. We'll finish this out with the infectious dermatologic emergencies. I have these listed as act now or things will go poorly, because true derm infectious emergencies can become fatal within a relatively short period of time. So what does this include? Well, this can include post-grooming folliculitis and furunculosis. I think this is one of the more common ones. Who has seen this? Some more hands are going up. Love it. Okay. So this is the bath reaction situation. These are patients typically with either medium, dense coats or short, firm hair coats, like pit bull coats, where the hairs are really thick, where the owner bathes them either at home or at a doggy wash place. And 1 day to 7 days from now, they present to you because they are acutely painful or they're just acting weird. It's actually uncommon that the owners see the skin lesions, especially in longer coated dogs. So they'll come into you, they may have a fever, they're kind of wincing, kind of acting weird, and you'll do your basic systemic exam, not really see much. And then when you start to look through their hair coat, even sometimes on accident, frankly, you'll start to see pinpoint draining tracks normally along the dorsum that may spread down the sides of the dog. And this is a German Shepherd that has been clipped, or you can see a bunch of draining tracks along the back. This is an acute form of deep pyoderma, which means we had infection from the skin go into the hair follicles, rupture, cause that furunculosis, and now we have bacteria that has free access to the bloodstream. So for these patients, it tends to go either staph or Pseudomonas. They are asking to become systemically unwell and do have a risk of sepsis. So when you see these patients, yes, you can biopsy them and culture them, because then you will have a definitive answer, and culture will help guide your antibiotics if we're dealing with more resistant bacteria. But these are patients where you do want to start antibiotics very early in the course of your treatment. So how do we do this? We get our samples. We may clip the longer coated dogs, so that way you can get topical therapy on the areas that are infected. This is probably one of the only times you will ever hear a dermatologist say that you should start a fluoroquinolone before a culture is pending, like, before you have results back. We never say that, right? It is not a first-line antibiotic. But because these tend to skew Pseudomonas and the risk of not treating is sepsis, you can start this kind of an antibiotic, a fluoroquinolone, so Enro or Marbo, at the high end of the dosing range until your cultures come back. And if it turns out then that it's actually a relatively sensitive staph, and this one wasn't a Pseudomonas one, great, you can de-escalate back to a cephalosporin, but at least you know that you had covered them in the meantime. This is one of the few derm conditions where steroids are not what you want to use. Everything I've talked about before, autoimmune, inflammatory, we are the steroid people. We love corticosteroids. But in cases of infectious diseases or suspected infectious diseases, you want to stay away from the corticosteroids. Necrotizing fasciitis is our next infectious emergency. This one is different. This is caused by strep canis, and it tends to be one limb, one part of the chest wall or the neck that is affected. And these infections are deep and rapid. So this is a dog that will be normal on a Friday, and by maybe Sunday morning has a swollen limb that is purpuric, so purple, erythematous, non-blanching, weeping bloody fluid. The dog does not want to put any weight on that limb. You'll go to the clinic. You may even do a cytology, and you only find neutrophils. You say, do I think this could be infectious still? Yes, because the infection is actually quite deep in. It's not a surface problem, and it has to do with the inflammation that is triggered by the Streptococcus canis, not just the bacteria themselves that leads to such an aggressive looking infection. And these are patients that require antibiotics ASAP, as well as potential surgical debridement or amputation. So these are not cases that you want to have sit in your clinic for a couple of days with bandaging. These are ones that need a surgeon to do severe debridement, or in this kind of case, consider potential amputation. So these patients don't look like your regular abscess. We've all seen dogs that have an abscess on their limb where it's localized swelling. Yeah, they don't want to put a lot of weight on it. It's painful, but they don't feel awful. These pets feel way worse than you'd expect with a regular soft tissue infection. They're febrile, they're painful, they're depressed, and sometimes their blood work can actually be pretty helpful, where they not only are going to be hypoalbuminemic, as you'd expect with an acute inflammatory disease, but they may have elevated liver enzymes or have a low sodium. So in human medicine as well, those are the hallmarks, are elevated liver enzymes and hyponatremia, to help you distinguish this from other causes of abscesses. So what do? We see this, we give them antibiotics, and you do want it to be one of your like ampicillin sulbactam, or if they're eating still, Clavamox. Fluoroquinolones are contraindicated in this condition. You get them to surgery, you submit samples at the time of surgery, and you avoid fluoroquinolones because it actually makes the issue worse. And even with doing all those good things, in that case series that I have here, the prognosis was still considered fair to poor if they were not treated within 24 to 72 hours. So my key points for this lecture is, when you see patients for derm disease, the first thing you want to do is make a decision if this is haired skin or non-haired skin disease, because that really separates the conditions very rapidly for you. You want to increase your confidence by asking yourself every time you see weird skin lesions, could I make this be folliculitis? Maybe it's just weird pyoderma, right? You're trying to talk yourself into that. And if you do your baseline diagnostics and it doesn't match and you can't talk yourself into a regular folliculitis, you already know you're moving into the realm of weird conditions. We want to use biopsy as a way to diagnose things that are unusual. So macules, blisters, ulcerative disease, and do that rapidly. You can biopsy with light sedation and local anesthesia. You don't have to wait days for general anesthesia to do this. And it's always important to ask about drug history when dogs have sudden acute onset of unusual skin lesions, because they are most oftentimes going to be drug eruptions. And as a general derm reminder, that if you have something severe and worrisome that you think is immune-mediated or inflammatory, you want to get out your corticosteroids now. The only exception is going to be when you feel convinced that it is an infectious emergency. That's what I got. Questions? Okay, well, I think we have a break coming up then.
All right, I just wanted to remind everybody, our security came and chatted with us and said there's quite a few cars in the client parking area. So if you are parked out here in the first few rows right in front of the building that's client parking, if you could politely move over to the staff parking, kind of just a little bit over on the other side of the lot, that would be very much appreciated, so those people with emergencies can get easy access into the hospital. Otherwise, we will take a short break here before our next session, which starts at 10:40. Thank you. We have another session with Dr. Gentry, and so we're going to listen into some things on pediatric dermatology. Thank you to those of you who moved your vehicles. I very much appreciate that. And I wanted to also share with you, we didn't have it up earlier, this is our QR code. So at the end of Dr. Gentry's session, we're going to have a Q&A with Drs. Upchurch and Gentry that we can talk about some things that may be further explanation, things you have questions on. We'll have a dedicated time for that at the end of this session. So take a look at the QR code. We'd love to have some additional questions. I see some of you online have been adding them, which is great. So we'll get a few answers to those. All right, welcome again.
Thanks. All right, so pediatric dermatology. In general, pediatric dermatology isn't too different than regular dermatology, but there are certain conditions that tend to skew toward a younger patient population. So I expect that during this lecture, a lot of it is not going to be new or novel to you guys that have been practicing in GP for an extended period of time, but it just kind of helps us organize our thoughts to what is a more common condition we should see in pediatrics and what we do when we think we have something a little more unusual. So we're going to briefly review, again, the diagnostics and the identification of our most common issues in pediatrics, which are pyoderma, demodex, and dermatophytosis. We're then going to kind of discuss how we work up these patients when maybe we're a little more drug limited based on their age. And then we'll go through the more unusual things, which are our genetic conditions and certain immune-mediated diseases that particularly like puppies and kittens. And then review how we can use punch biopsy technique on these more unusual things. So what's common if you are a puppy? Okay, well, in my opinion, if you have skin disease and you're a puppy, it is almost always going to be something from this list, right? Fleas are super common in puppies that come from group housing situations, as are mites, both that are contagious and not. Ringworm, although more common in kittens, certainly happens in puppies. And then as time has gone on and we have this increased love of brachycephalic breed dogs, we are seeing allergies show up in younger and younger patient populations. So let's go through these. So what diagnostics do we use when we are worrying about pediatric diseases? Same diagnostics that we already know and love, and they are especially important in peds because you have to distinguish those three causes of folliculitis because they are all on the table. So deep scrapings and trichograms for mites, superficial scrapings for Sarcoptes, impression cytologies for any of our infectious diseases, all the testing for ringworm depending on what situation you are in, and then using treatment of ectoparasites as a diagnostic test. So flea allergy, do y'all get a lot of flea allergy here? Is that still a problem? Yeah, still a problem? Okay, sorry, I was hoping you'd be saying no, and I'd be like, lucky you. So flea allergy is the most common allergy still in the United States, right? It was especially a problem in the southern US, and it can start in pediatric patients. So if they've been exposed to fleas since puppyhood, by the time they hit 6 months of age, it is not unusual to have the rump-centered dermatitis. And this is different than just having a flea infestation. If I'm a dog that's not flea allergic, but I'm covered in fleas as a puppy, I may be a little itchy and have more of a rash around my ventrum, but I'm not going to have this pattern of tail heads, rump, and tail base itching and scratching. So it's a very classic appearance, and the treatment is flea prevention for everyone. But what about demodex mites? These are really common in our puppies, even though I think we have the isoxazolines and we're getting rid of maybe that mid-age one from 4 months to a year because they've seen you. But it still isn't unusual for patients that have not seen preventions and come from group housing situations to have demodex. These are considered our non-contagious mites, right? You have to get them from somewhere. So you get them from your mom when you are 2 to 3 days old, and then after that, they become a non-contagious mite in the dog. And as I mentioned before, and Dr. Upchurch mentioned as well, the typical form is going to be D. canis. That's the one that enjoys the bully breed dogs, anything with a smush face, as well as Shih Tzus. And then you will get the Demodex ingi, which is the back-centered greasy form in our terrier breeds, particularly the Westies and the Scotties. How do we get Demodex and how do we classify it? Well, I like to classify it because then I can have a good idea whether I should actually be worried about this dog having or puppy having Demodex or not. If it's when they are really young and you know they came from the shelter or someone found them in an alleyway, and they have a bunch of roundworms, or they are just pooping out in front of you in your office, none of us are surprised that their immune system is not handling the Demodex mites and they're having Demodex mite overgrowth. We're also not really concerned in any pediatric pet because having an immature immune system makes you more likely to develop demodicosis. And having a stressful life makes it easier for that to happen as well. So if we have young dogs that develop Demodex, even if it's generalized, I don't worry about them becoming an immunodeficient adult dog that's just being a puppy. And we treat it whether it's localized or generalized. Historically, again, depending on the time you graduated, we made this really big distinction between saying localized disease, you don't treat it, it'll go away on its own. And that's still true to this day but now we have isoxazolines, right, that work really well and are something we're going to do long-term anyway, versus having to give dogs daily ivermectin for a solitary lesion. So in my mind, in this day and age, you should treat Demodex whether it's localized or generalized because we have safe and effective products to do so. My only tiny caveat to that is if this person really wants this to be their breeding dog, and we know that it's a genetic condition in certain breeds of dogs, if their dog has demodicosis and they want to know if they would self-clear because they want to breed this animal, I'm going to let them see what happens, right? Because if the dog develops severe generalized disease, you know that's likely going to be passed on to the next generation, and perhaps that's not the best choice. We also know that although we don't use as many immune modulators in puppies, we do sometimes for conditions we'll get to later, and that can also predispose them to developing this. So what does this look like? Well, it's folliculitis. So by rule, right, it must affect haired skin and the hair follicles. But what makes it look a bit different from our other forms of folliculitis is that it tends to have more comedones. So this is the one that has more blackheads compared to pyoderma and dermatophytosis. And you're going to see follicular plugging. It also tends to cause much more hyperpigmentation of the skin. So if you show me a circular lesion of folliculitis, let's say an epidermal collarette, which is scale around the edge, and the center is pink, I'm going to say pyoderma or dermatophytosis. If the center of it is really hyperpigmented in a young dog and there's comedones, I'm going to lean Demodex. It's not a perfect rule, but it tends to follow well. In puppies, demodicosis can be itchy, but it doesn't have to be. So I would not exclude this as a possibility because there is or isn't itch. And here's an example of this really cute puppy that has quite widespread disease on its face, chest, and paws. Juvenile onset demodicosis can look very similar to allergy. So in the first two images, we have a young dog that's just a little bit itchy, came to me actually as an allergy referral. She's under a year of age, but just has alopecia along with more diffuse hyperpigmentation. And as we had said a few minutes ago, okay, hyperpigmentation can track with allergy, but it also tends to track well with demodicosis. So this was a patient that just had not had the initial diagnostics at their primary care veterinarian. It can also look more nodular, like deep pyoderma, because if you get enough mites in your hair follicles, and now there's like 15 mites in the hair, it's going to explode. And when it explodes, you get furunculosis, or exploded hair shafts with free mites in your dermis, and that causes a really big inflammatory reaction. Your body doesn't like the idea of free hair and free mites in your skin. So if it gets to that degree, it can look much more severe. So, as discussed earlier, it's really easy to diagnose this condition in the dog that will sit still long enough for you either to collect a trichogram, or hair plucking, right, or to get a deep skin scrape. I would say that at this point in my career, I'm almost exclusively using trichograms, and I will only scrape if the trichogram is negative, but I still thought it could be, because By rule, trichograms are slightly less sensitive. So how do we get rid of this nowadays? We're so lucky we live in the time of isoxazolines. We just need to give them their isoxazoline that we would have anyway for their flea and tick prevention at the on-label dose and the on-label frequency. We're not having to do anything out of the ordinary, and that makes our lives very easy. And this is an example of a patient just treated with a Foxolaner, so NexGard, 1 month apart. And this was like a 4-month-old puppy. So the improvement is incredibly rapid with these drugs. For those of you guys like me who were trained in the time of oral ivermectin, remember how it took like months for those dogs to get better? Everyone's nodding along like, yeah. That's the nice thing. So if I think the dog's skin lesions are all caused by Demodex, and I give them an isoxazoline, and like 6 weeks from now they still look really bad, something else is probably going on, right? It's not like ivermectin where you're waiting 2, 3, 4 months for this to happen. If you have patients that you know have neurologic signs caused by the isoxazoline use, then my alternative suggestion is to use Advantage Multi at an off-label frequency every 2 weeks. You're using the moxidectin part of it, not the imidacloprid part of it, to treat the Demodex mites. What about sarcoptic mange? Sarcoptic mange is also common in puppies because it's a contagious disease that they need to be on preventions for it to not happen. So any puppy that comes from the outdoors or group housing is at risk of developing scabies. Unlike Demodex dogs that have maybe some itch, these dogs should be extraordinarily pruritic. Like these are the dogs that when we describe them, we'd say they have intractable itch, right? Like you'd like pull their face off their leg because they're chewing it so much, and then they go right back to it. These animals should be very, very itchy. And the pinnal-pedal response is a pretty good test for this condition. What you're looking for in lesion areas are going to be the edge of the pinna. So unlike immune diseases that cause yellow crust where it's the concave pinna, this is the edge margin of the pinna, the elbows, the hocks, and then the paws as well. So in these images, we have an adult friend, and then here we have a cute little line of eggs. Because it is hard to find adult mites, especially when the disease is relatively new, you know, they have little crusty elbows, they have the pinnal pedal, and you're like, I'd like to find some mites, but I'm not seeing adults. That's okay, I can't find the adults either. But what I can often find is an egg or two, because you can't have eggs if you don't have an adult, right? And sometimes I don't even find that. I find scabies poop. And I apologize, I didn't put a great photo of scabies poop, but there's a few in the background up here. It looks like rabbit pellets, just in a tiny version. So if you're seeing little dark black blobs and you think the dog has scabies, the only way to get scabies poop is to have scabies. So you can be pretty confident in your diagnosis, even if that's all you find. So what does this look like clinically? It can look like a lot of things. This is kind of the poster child in my mind. This dog is incredibly red on the elbows down, the hocks down, and has scratched itself so much that it's lost all of the hair in those areas. You may also have this yellow to off-white crusting on the convex and the pinnal margins, as well as having disease around the paw pads. Sometimes these crusts will actually basically approach or cover the pad itself, making you question whether this is in haired skin or affecting the non-haired paw pad. But usually if you lift it up, you can see that there's a line between the two. So don't let that fool you. So how do we diagnose this? As we talked about, we scrape. It's not always findable. So our test is response to therapy. If you have a pruritic puppy and you give it an isoxazoline and 3 weeks later it is no longer pruritic, you had some sort of itchy friend, whether it was scabies or maybe it was Calatiella you just didn't see, or even the rare case of lice. That's great. They're better. We're thrilled. Okay? Sometimes, though, these patients will come in and they're really, really little, like they're below the age for the isoxazoline, or their weight is like 2 pounds. If you don't have an isoxazoline that fits the age range or the weight of the patient and you're trying to stay more on label, you can consider the 0 to 5 pound revolution, right? That's selamectin, and it comes in that puppy/kitten form of really tiny animals. And I just use that every 2 weeks. Ivermectin also still works really well for this. So if this is a group situation or a lower cost situation, you have a bunch of scabies puppies, it is still a-okay to use ivermectin for these kiddos. It'll be cost effective and it will work. Lime sulfur dips. Who likes lime sulfur dips still? Okay, I will admit that I still do, and you're like, okay. But why? I really like it for scabies where it's thickly crusted. I think of those as the high-rise apartment scabies, right? So if I give a systemic drug, and the mites that are really up high are not going to burrow into the epidermis for like a few days, or they'll take their time before they go down there. If you lime sulfur them, all the high-rise apartment scabies mites die off rapidly too. So even if you only use it once or once a week for the first few weeks, it really can rapidly speed the resolution of this, and it kills the mites that would then flake off into the environment and potentially infect other animals. And because their skin barrier is damaged from having a mite infestation, it's not uncommon to see some level of bacterial overgrowth. And with our goals for judicious use of antibiotics, that's where I'd rather use a shampoo or a mousse, at least initially, because we know once we get rid of the scabies, their skin barrier is going to be normal and they probably won't even need an antibiotic in the future. So ringworm, again, some of the same images from before. This tends to skew toward the really young puppies, right? Once they've hit 5 or 6 months and they have a more competent immune system, we're not seeing ringworm very much anymore. But when we see it, it has that classic follicular-centric appearance where it's usually annular to oval on haired skin only. The special form of ringworm, though, that I want to talk about a little bit more in this presentation is the dermatophytic carrion. We have seen these before. These are fun. So these are pretty acutely developing within like a week or so, that they can look near identical as a dome-shaped red mass to either a mast cell tumor or a histiocytoma, especially in a puppy, or some other inflammatory reaction. They are frustrating because although they're often microsporium canis, they don't fluoresce like they are supposed to. It's like the dermatophytes are hiding within this dome. And so you're actually better off getting an answer on this is dermatophyte from either an FNA of these, usually under sedation for a wiggly puppy and a face lesion, or from an aspirate. Occasionally, if we're still not convinced that this is a histiocytoma or a fungal carrion, then biopsy is going to be your best bet to differentiate them. So it tends to be the young dog that is a sporting breed that is going to go outside, shove their face into something in the ground, therefore traumatize their skin barrier a little bit, allowing that ringworm to take advantage of them. So now let's talk about allergies, because in theory, right, if we have seen pets and we said, okay, you come in and you're itchy, and maybe you have fleas, I don't see any, maybe you have scabies, but I couldn't find any, I'm going to give you an isoxazoline. Okay, but you're still paritic. I don't see any annular lesions that make me think about dermatophyte, or maybe I toothbrushed you just to make sure it's off the table. Once we've gotten through the infectious diseases in puppies and we're still having itch, especially if it's widespread, we're likely dealing with juvenile onset allergy, which is becoming more and more common in the landscape of an increased interest in brachycephalic breed dogs. So food and environmental allergies in these young animals is clinically indistinguishable, same with adults. So the old adage of like, remember ears and rears, if anyone heard that one at one point, that doesn't, you're laughing now, that doesn't really hold up anymore because some poor dermatology resident did a study where I think it was up to 50% of environmental allergies had bum itch. So we can't use that as a distinguishing factor between the two anymore. What also is frustrating to help differentiate is normally when I have an adult dog come in and the dog is 3 and I say, okay, tell me about their itch. And they're like, well, the summer's really bad and then it's not as bad in the winter. Okay, well, that's an obvious seasonality. I think it is much more likely that that dog has environmental allergy. But in the pediatric population, they haven't had time to go through the whole year. It just may be spring when they were born, and now they're itchy in the summer, and you don't know if it's going to go away in the winter or not. So it is hard to show seasonality. So typically in a pediatric patient that is paritic, where you know it is not ectoparasites anymore, the next step is going to be a dietary trial. And I know we talked about this a little bit already, so I'll go through this pretty briefly. So in my mind, diet trials last 6 to 12 weeks, assuming your skin is clean, meaning you don't have ectoparasites still on you, you are not covered in infections, because having any of those things will muddy the waters to get an answer if the diet is helping. There have been several cool papers out talking about how if we give corticosteroids at the beginning of a diet trial, we can significantly shorten the length, which is good, because compliance is an issue for diet trials. And if we have clients that don't want to feed this expensive special food for 12 weeks, I understand. They just got a new puppy. It has lots of new puppy expenses. So what you do is you typically give them 0.5 mg per kg of prednisone or equivalent. And after 2 weeks, you taper it off, finish by week 3. If their itch immediately skyrockets again, you are leaning toward environmental allergy. So you give them another 2 weeks of corticosteroids, and then you stop it. If you hit week 6 with the use of a corticosteroid while there's no infection and you're on good ectoparasite prevention, it is very, very, very likely that they have an environmental allergy, and you can scrap the food trial relatively early, okay? You can also consider Cytopoint if the pet is itchy but not inflamed, but it doesn't have the same effect of decreasing the length of the diet trial. But if I gave a Cytopoint and their itch went away as I changed their food, and their itch comes back exactly as Cytopoint wears off 35 days later, you're making a better case for environmental. As a reminder, right, that in pediatric patients, you have to consider different foods than you do for adults. You need them to be labeled for growing dogs, ideally. And there are, as Dr. Upchurch mentioned earlier, a good amount of options that we now have available to support them nutritionally while ruling in or ruling out a food allergy. So my kind of during the diet trial things, I want to make sure they don't have secondary infections, because the most common consequence of allergy is having infection. And I can't tell you how well a diet trial worked if when you come back at your 8-week mark, you're covered in pyoderma that makes you itchy. So typically we're using antiseptic preventative therapies during that point, right? So have them bathe in the chlorhexidine shampoo, have them put the mousse in the areas where they've had pyoderma before, because you don't want things muddying the water. Make sure they know to remove everything else that is potentially edible from the dog. And I like to keep a stack of like a week or 2 of their old food on hand for the challenge phase. So, as was previously discussed, you kind of have a couple options when you challenge the diet, right? One is you had that old food and you feed it back to the dog because you're not convinced either way. The dog's itch doesn't go up within a few days. We say up to 2 weeks, but truthfully, most dogs will itch within a few days to a week. The itch doesn't go up, it's not a food allergy. It just happens that it's now the winter and they're not itching anymore. If you feed them their old food and the itch goes up really, really high, then they have 2 choices. They can either say, 1, but I love my Hill's Derm Complete, it's delicious, and I'm going to feed my dog it forever, and you say, grand, our problem is solved, see you at your annual. Or they say, but I really wanted to give him more snacks or other foods. And that's when you do the individual diet challenges, where you can make these little spreadsheets you can print off online and go through some of the common allergens. So if it's chicken, the one you're doing first, you give them some cubed cooked chicken every meal, and if they start to get horribly itchy at day 2.5, that's a no food. You mark that with an X. You let them calm back down. You maybe give some corticosteroids so they're not so itchy, and then you move on to the next food. Because there's some dogs that are only allergic to 1 or 2 ingredients, and you can find an over-the-counter diet that they want, or multiple snack options. I've also found dogs that are allergic to every meat I have possibly tried and have to maintain a vegetarian lifestyle. So they come in all types. But what about the early onset environmental allergies? So this is typically the Frenchie, right? Or the English Bulldog that came to you itching at 8 to 9 weeks of age. And you checked for mites, you put it on an isoxazoline, it doesn't have any indications for dermatophytosis. By 12 weeks, because it was still itching from 8 to 12 on isoxazoline, you did the food trial. Now we are approaching 6 months of age and we continue to be peritic, right? You have an early onset environmental allergy that requires chronic management. And here's a little kiddo. He was 3 by this photo, but he had been having itch since he was 7 weeks of age. So what do we do when you are a baby dog and you have allergies? Well, there's a little less options that we have because there's age restrictions for some things. But the things that are free-for-alls in my mind, Cytopoint has no age or size restriction. But since this is such a narrow drug for itch that does not target inflammation, dogs that have skin inflammation, which generally are Frenchies and English Bulldogs, may not have a complete benefit from this drug. Steroids don't technically have an age restriction, but I understand the always concern of not going hog wild with corticosteroids in baby animals. Like, we're trying to be reasonable about this, but if you need it, use it. Hydroxyzine or antihistamines, right, can be used for any age animal. The reason I specifically put hydroxyzine on there is, as a derm community, we're moving away from oral Benadryl, because there was a study where they gave dogs Benadryl and other dogs cetirizine, and then they did a histamine prick test to see how they'd react. And there was no dampening of a regular wheal and flare to histamine if you were given Benadryl, but there was with cetirizine, which is what's in Zyrtec and hydroxyzine. And we also know that oral Benadryl has minimal, 8% bioavailability. So injectable Benadryl for allergic reactions, good. Oral Benadryl as an antihistamine for pruritus, not really good. And I would suggest moving toward hydroxyzine, which is a 2 mg per kg dose twice a day, or a Zyrtec at a similar dose. Omega-3 fatty acids have no age restriction, so you can always start those, knowing that it'll take 12 weeks to take effect. And it's always a good idea to be starting on our topical therapy early for these dogs. Things for skin barrier repair, things to prevent infection so we're not having 4 courses of antibiotics before their first birthday, those type of things. The drugs that are likely to be used for these pets long-term, though, have age restrictions. Cyclosporin is labeled for 6 months and up, while oclacitinib, so Apoquel, and ilunocitinib, Zenrelia, the newer JAK inhibitor, are both labeled for 1 year and up. I will say that in my practice, I'm pretty good about keeping to those rules. Am I going to come to your clinic and fight you because you gave an 11-month-old dog Apoquel after you've done the entire full workup and they're really itchy? No. But I would not be giving oclacitinib or Zenrelia to presumed allergic dogs that are 4, 5, and 6 months of age because we have options that are less risky. But what about the weird things? So now we've done the regular stuff. What's weird in puppies? Well, there's a couple of them. We got post-vaccine rabies paniculitis. We got dermatomyositis. We got puppy strangles, another favorite of mine. Chin acne and ichthyosis. Let's look at some of those photos. So rabies vaccine-induced vasculitis paniculitis is actually a form of an ischemic dermatopathy mixed with a paniculitis. So what does that mean? So ischemic dermatopathies are that subset of vascular skin disease where instead of your vessels clogging all at once leading to dead skin, it's like you're slowly siphoning away the oxygen. So the skin slowly starts to get thin and die back, leading to this atrophic-looking scar where there may be a central ulceration. But what's happening way below the surface initially is that your body is developing paniculitis or fat inflammation around the adjuvant of the vaccine. So deep down in the skin, it's very inflamed and then slowly suctions oxygen away that what we see looks like a atrophic scarring disorder. This is most common in our dogs that never leave laps, right? Like toy poodles, Maltese, things like that. And it should always be where you gave your rabies vaccination. It can be your puppy one, and in some cases it's like the follow-up one right at the 1 year mark. This is not like a vaccine reaction where they're going to tell you they saw this within a few days. Occasionally they'll say a few weeks after the vaccine they noticed a bit of a nodule. That's the paniculitis part. But often they don't come to see you until there is an area of hair loss right over the site of your vaccine a few months later. And it can look pretty quiet, just like a scar, or it can have that central ulcerated appearance. What is worrisome about this is in some dogs, this will also trigger a widespread ischemic dermatopathy, so a vasculitis everywhere that will then start to affect the claws, the paw pads, the pinna, as well as the tail tip. So you want to check other areas for that. This is typically a repeatable problem, which is frustrating for a vaccine that is a core vaccine, that if we vaccinate these dogs again, we can expect that this will happen again and potentially triggering a more widespread version of the disease than you had before. And we treat this like we do most ischemic dermatopathies with pentoxifylline, occasionally corticosteroids, and as they get a little bit older, oclacitinib. This has been gradually phased out, I think, of most of our population. This is familial dermatomyositis. It was more of a historical problem, although I have seen a few cases, which is why I have some images still. This is a genetic form of an ischemic dermatopathy. So another vascular disease, but it's genetic and typically shows up in relatively young puppies. Because it's ischemic and the skin is dying, you again have alopecia, depressed looking skin, and it was erosions that may be topped with crusts. Some of these patients will also have the myopathy associated with it, where they have trouble opening and closing their mouths and seem to have muscle loss along their distal limbs. Some of these dogs, it disappears after a few months. We don't know why. We assume there's some sort of compensatory mechanism happening, but many will have diseases. So if I saw this puppy and I was like, okay, well, there's hair loss and crusting, it's haired skin only, I would still do my basic derm diagnostics. I get a cytology. May I find a few bacteria? Because yeah, there's an open hole in the skin. I see some bacteria. I Woods lamp it. I check for dermatophyte. I check for Demodex with a trichogram. all those things are negative, I use that information and the breed to say it is much more likely to be this genetic / autoimmune condition, and I may biopsy it if the owner wants that direct information, especially if they were considered breeding that animal. Puppy strangles. I feel like a lot of us have seen that, right? We've been doing the baby strangle dogs. So these are dogs, the typically larger breed, but any breed is on the table, where they are fine one day, and by the end of the week, they are febrile, lethargic, probably hyporexic to anorexic, and have severe swelling around their muzzle, their eyelids, their concave pinna, as well as the lymph nodes. It might be even both, maybe one or both of their submandibular lymph nodes. And not only is the tissue swollen, but it tends to have a furuncular looking look. So there's little nodules in the inflamed tissue. So if this eyelid, for example, right, the whole thing is swollen, but there are little pieces of it that look like there's discrete lumps of tissue. This is a autoimmune pyogranulomatous dermatitis, that for some reason your immune system is triggered to throw down a whole bunch of neutrophils and macrophages into your skin. In the more severe case of these puppies, their lymph nodes are going to be like golf ball size, if not bigger, and sometimes they will abscess their lymph nodes, which is where we get the strangles name from horses. So here's another example of a poodle puppy with widespread tissue damage with crusting on top of both the face and the limbs. This is where it starts to get a little bit scary, right? Because this puppy was normal one day and not 7 days later, which makes it a hard case for ringworm or Demodex or even dermatophyte, right? But I can still, with these puppies, do my basic diagnostics. But then having a combination of fever and lymph node enlargement, you are most likely dealing with this condition. A biopsy is going to give you a definitive diagnosis, but I think there are a lot of these cases where biopsies for spectrum of care reasons are not on the financial table, and that's okay. I think you can be pretty confident with this condition. But what I think is the scarier part is asking someone to give their 9-week-old puppy 2 mg per kg of prednisone until clinical remission. So I agree that we all kind of like clinch a little bit, but we're going to do it because that is what's going to make these dogs better. They don't typically require long-term immune suppression. They often get better after 2-3 weeks on the higher dose, and you can slowly taper them off by 8 to 12 weeks of therapy. So that is good. Chin acne and chin furunculosis. This is often associated with allergy in adult dogs, but in puppies, it's associated with the dogs with the giant heads. Cane Corsos, really big American bulldogs, large pit bulls, where they have these stiff, hard hairs and these giant floppy faces that they just smack into the ground repetitively because they have no self-control but using their face, right? And when they do that, you're like, yes, I've been like attacked by one facially, right? They just jump into your face with all the love in the world. When they do that, these short, stiff hairs are being traumatically shoved out the back of the hair follicle, leading to furunculosis. So now we again have free hair in the dermis. Your body does not like that, throws down a bunch of inflammation leading to a nodule, and now they've got an inflamed, itchy nodule that now they're like scratching at their chin and excoriating it. And so when this happens, often what we are doing is treating topically if it's mild, or systemically if it's not, with a corticosteroid to calm the inflammation, and then using your cytology to see whether or not it's just inflamed, or if we now have developed secondary infection that requires antibiotics. Ichthyosis was already touched on today, right? But this is a condition that we see in certain lines of golden retrievers. We're also now seeing this in Labrador retrievers. The same gene has been shown in a group of labs as well. So don't just take it off your list if it's a non-golden retriever dog. These patients should have excessive scale that's either white or gray, and it's ichthyosis from fish, because if you look at some of the scales close up, they have almost like a mottled scale-like appearance to them individually. In the golden retriever, it is by rule a cosmetic issue because it's what we call non-epidermolytic ichthyosis. That means the scaling is on the top, but the structure of the skin itself is fine. There are specific breeds of dogs, I think it's the Norfolk or Norwich Terriers, that have like an epidermolytic form where their skin's actually damaged, but that is extraordinarily rare. One thing to diagnose this before they start scaling is to look for the silvery belly. So if you are a practitioner who often sees litters of Labradors or Golden Retrievers for kind of first exam from a breeder before they go to a new home, flip them all over and look at their bellies. Because if they have ichthyosis in any of their lines, these dogs tend to have a silvery belly that you'd associate normally with like chronic allergy hyperpigmentation when they're like 8 or 9 weeks of age. So way too early for them to develop hyperpigmentation from allergy. They'll have a silvery belly, even if they haven't started scaling yet. So if you see that, you can mark that in your record and at least hint that you're worried they'll develop scaling soon. Even though this is genetic and they can be really scaly as puppies, and this is actually one of our IM residents' dogs. She bought a Golden Retriever that happened to have ichthyosis. Not only did he have a silver belly, he was covered in scale. But by 9 months of age, he was normal. His genetics didn't change, but these dogs will often have compensatory mechanisms in their skin. The skin is redundant on purpose, so these things don't become fatal flaws, that he has no more scale anymore. So there is hope that some dogs do seem to outgrow it. It's what was historically called milk crust, if you've ever heard that from an older practitioner, because it was ichthyosis that just seemed to resolve as they got older. But if the dogs do not resolve with time, then we treat it as a cosmetic issue and may do some things like fatty acids or moisturizing products to make it less noticeable to the client. The last one on here is color dilution alopecia. With our love of brachycephalic animals, I think we also have started to love the dilute colors as well. And these dogs will present you at their 3-month visit with a full blue or fawn hair coat, but as they're hitting the end of puppyhood and maybe early adulthood, the coat has started to fall out. Because when you have color dilution alopecia, your melanocytes who are making your pigment are doing something wrong. They are just shoving the pigment into the hairs so haphazardly with these giant clumps of pigment, which seems weird, giant clumps, but you have no pigment, that to us it looks dilute, and these giant clumps cause the hair structure to be damaged where it just cracks off at the surface. So they're not losing the ability to make hair. Their hairs are just being made so, in a sense, incompetently because of their melanocytes going awry that the hair falls off when it hits the surface. So that's dogs. So I have a little less time to hit cats, but I may go a few minutes over and I apologize. But kitties. What's common in kitties? It's always ringworm, right? Like, that's why someone would be like, you wrote that 3 times. I know, on purpose. So in kittens, it's like ringworm until proven otherwise, right? If they have hair loss or they have scale or they have a little bit of itch at their face, it's ringworm. But if I can rule out ringworm and fleas and some of their common ectoparasites, then we'll get to a few weird things at the end. So diagnostics for kitties are the same ones that we talked earlier, except that we put our ringworm testing as our #1 diagnostic tool. So feline ringworm looks typically like hairless circles to ovals that may or may not have scale, and in some cats does have a little bit of erythema. It can be really quite boring looking. We just got a few little spots here, and the cat's overall happy and healthy. It's typically going to be the face, ears, paws, and tail, because face is where it starts. Kitty washcloth puts on your feet, and tail because they sleep with their tails in their face. So here's a more severely affected kitten where you have widespread alopecia with scale, but none of it's typically circular or annual. It's just kind of like a patch of affected skin. So don't use the circle thing for folliculitis to trick you for that one. And we have a woods lamp where we have glowing hairs, which is important, not just scale, because that doesn't count. So how do I diagnose ringworm? We see a lot of ringworm in Texas. Do you guys got a lot of ringworm here? I mean, we see so much of it. It's like every kitten has ringworm that comes into the ER as a good Samaritan. And so for us, what we are typically using is woods lamp screening initially, because a lot of our M. canis glows, which I appreciate. So we have a glowing pinna. That to me is a diagnosis. If it is the full length hairs that are glowing and no scale that is glowing, I'm satisfied with that, right? If you want additional confirmation that's table side, I then suggest grabbing some of these hairs and looking under the microscope, because you will see all the spores along with your inflammation. So you have woods lamp, cytology, and trichogram to get an in-house diagnosis without having to send anything out. If you are mobile, let's say you don't have a microscope and your woods lamp is negative, that's totally reasonable. You can always send out for a DTM or a PCR. As a fun shout out to naked cats, because I like them, their ringworm looks more like people ringworm, where it's like circular areas. So even though they are naked, they still in fact have hair follicles and hairs. Their hairs are just really dysplastic and break at the skin surface. So don't rule out that they can have ringworm too. In kittens, depending on the age, you may want to consider systemic treatment, right, which is typically terbinafine or itraconazole. For itraconazole, our on-label product is that itrafungal liquid that as the cats get older becomes quite a large volume of liquid that is not always enjoyable. But terbinafine tablets work really well because at 30 mg per kg, if we have like an adult-sized cat at 5 kilos, then we're at 250, so that's perfect, it's a whole tablet. 2.5 kilo cat, half that. So you can do quarter, halves, and 3/4 terbinafine tablets for relatively low cost and good efficacy for ringworm in kittens. I still, again, like my lime sulfur because it is effective and because it keeps the hairs that are then shed in the environment from affecting additional animals. Because often when someone has a ringworm cat, there's not just one cat in the household, right? Like this is cat number 7 typically, right? And so now we're like, oh gosh, we got this new kitten. He has ringworm. The other cat in the cat house has IBD and is on chronic prednisolone. Everyone's going to have ringworm soon. So that's the place for lime sulfur where we know they're not going to be able to isolate the kitten perfectly, but we want the hairs that are shed to not infect every other animal in the household. There is one unusual presentation of ringworm that I think it's nice to just keep in the back of your mind. This is the dermatophytic mycetoma. This is where the ringworm was on the hair follicles like normal and somehow escaped and is now living in your subcutaneous tissue. That's really rare because in general, right, it's a keratin-needing and loving fungi and it shouldn't go below your skin. But if this patient has a genetic reason that is immunocompromised that we see in certain lines of Persian cats, or was misdiagnosed as allergy when it was ringworm, which was this kitten, and was given corticosteroids for months, his ringworm that was on his pinna has gone under his skin into nodules. So if you happen to see that in kittens, it's diagnosed by biopsy and it is treatable. Cats get notoedries, right, instead of Sarcoptes. And notoedries really likes just to stay on cats. So unlike Sarcoptic mange in puppies, where we're worried that like humans will get a transient form or like the cat eventually may get it, notoedries really is cat loving. So this tends to stay in this population. It can become severely crusted in kittens that are outside and malnourished and are overall having systemic stress. And unlike scabies, where the mites are hard to find, these mites are very prolific. So if you think it has notoedries, you should be able to find some friends, and I think that's great. So here's an example of a baby kitten, and I'll show you his full face in a second. So this is him. This cat came to where I was working in private practice. He was, I think, 0.9 kilograms, and he was literally found in a trash can in downtown Houston, and this cat rescue picked him up. And so he has very classic signs of this light yellow crusting all along the pinnal margin and crusting right around the paw pad margins, which you would say, well, if it's around the pads, is it autoimmune? But it's just the edge. It's not the central part of the pad, right? So that should sway you a little bit. These animals are usually very itchy. And like I mentioned, you diagnose them by scraping or response to therapy. So here's him. And because he was 0.9 kilos and I didn't really know how old he was, I assumed very little, we ended up treating him actually with Revolution, that puppy kitten Revolution, and lime sulfur dips. That's what the rescue agreed to do. And here's him a month later. It was a trash can Persian. Like, I don't understand how that actually happened, but he's very cute now and he got adopted. And because this is contagious, every cat in the household should be treated. But what about kitty allergies? In a good way, that's actually more uncommon to see allergic cats present before 1 year of age. They are much better at presenting in adulthood. So when you have a paritic cat, the odds are much, much higher compared to the dog that you are dealing with something infectious, whether it's an ectoparasite or dermatophytes, and not as much allergies, right? So do allergic kittens exist? Yes, they're just much smaller patient population. And they can present with any of the regular allergy cat patterns. So the self-induced alopecia, or the eosinophilic plaques, miliary dermatitis, any of those things. And we rule out food allergy first. So let's end with the cat things that are a little bit more unusual or more regionally dependent. The first one is mosquito bite hypersensitivity. Do y'all have that here? You're so lucky, such lucky people. Then I'll go through it fast. So if you ever decide to move to the south, We get this a lot. It is an issue where cats that go outdoors get bit by mosquitoes, and it can lead to scarring over time, but it starts as little crusty papules on the nose, the convex surface of the pinna, as well as around the foot pads. So it can kind of have some overlap with notoedries. And this is a more acute presentation in a young cat, where it looks like just little hemorrhagic dots. And again, the margin of the paw pads are affected, but not the central part of the pad. And really the only treatment for this is you don't let your cat go outside when there are mosquitoes. Okay. So if you live in the South, it's like the cat needs to be indoors because, one, we don't have a lot of good preventatives for cats that also have repellent activity, right? Because a lot of the repellent products are permethrin products, and we don't put those generally on cats. And so there's no way to stop them from getting mosquito bites. But temporarily, when they're flared up like this, they respond very well to corticosteroids. So that's typically what we do. If you're in the South and you see that in a kitten, and you ask if they go outside and they say, yes, he loves the back porch, the answer is no. He doesn't anymore, and he should stay in the house. But if it gets really bad and they've been really excoriating in their face because it is itchy, it can be really hard to tell from pemphigus foliaceus that happens in kittens, from herpesvirus dermatitis, and from dermatophytes that's kind of gone wild. So I will always be okay with saying these are reasonable to biopsy if you're not sure, because they are hard to tell apart. Demodex gatawai, do you ever get any of that? I had only one case when I lived in Denver, and that was because someone had adopted a cat from a rescue group that was centered in Texas. So this is more of a Southeast United States problem. This is the one contagious Demodex mite, right? Everyone else, you get your Demodex, you keep them forever, they're your problem. Versus this is that short-bodied mite that can jump from cat to cat. And it's not as common, at least it wasn't in Colorado, so I presume not here. But if you have clients that work with rescues where they bring kittens from the South, this has to be on your radar for an itchy cat. They will overgroom until they are bald anywhere that they can reach when the disease gets significant. But they may not be very red, so they can look identical to the allergic cats that just lick without inflammation. These mites are super hard to find, so if you find them, that's awesome. Sometimes you find them on their housemates that aren't as itchy, because it's like fleas where there's a hypersensitive component to it, where they may all have the mites, but only some of them will really go after themselves. And that's what they look like, little stubby guys. And like most things that we've talked about, because our lives are easy now, the isoxazolines are very effective at treating this at just a regular on-label dose or frequency. Again, if they don't have access to that or they do not wish to, lime sulfur dips are very effective. And using the moxidectin in Advantage Multi for cat weekly to every other week can also help. And here's the same cat from Denver before and after. Kittens are more likely than puppies to develop pemphigus foliaceus. Does not mean puppies don't develop pemphigus foliaceus. They do, whether it's vaccine-triggered or idiopathic. But kittens seem to do this a little bit more often, and we do think that there's probably a decent link between vaccines and then a few months later developing this. So these are kittens that were maybe normal at their first or second kitten visit, but sometime in between became itchy, they may be scratching at themselves, but are having crusts in places that are not haired skin. So they're often going to have their nasal planum affected, the margin of the eyelids, the concave surface of the pinna, versus everything ectoparasite we've talked about is the margin or the convex surface of the pinna. And they generally don't feel well. They may be febrile. And my favorite type of pemphigus, and you may have seen this in practice, is when you look at their toenails, they almost see like they're flicking their fingers like this, like they're doing this a bunch, or they're biting their nails, and you lift back their claw bed, and like green pus starts like squishing out. Anyone ever had one of those? I mean, like, what is this? It's most often pemphigus in cats because it can just affect their nail beds as the only sign. So what we're looking for is pustules, which one could argue, but that's folliculitis. But these pustules are really big and seem to have no interest in the hair follicles. Okay? We also have a pustule on the paw pad itself. And because paw pads can't get folliculitis, seeing a pustule there already means it's something weird. And when you do your cytology as your baseline diagnostic, not only are you going to see neutrophils that are usually pretty happy and non-degenerate, unlike pyoderma where they look sad and disheveled, but you have acantholytic keratinocytes, which are the nucleated skin cells that have lost their adhesions to their friends, and that's why they are free and visible. That's the whole pathogenesis of pemphigus, is that you lose your friends as your skin cells too early. So how do we diagnose this? Well, this is when we break out the biopsy punches, because it's an atypical autoimmune disease, and because if that's what's happening, that may affect our urge to give certain vaccines in the future, and maybe a long-term condition the owner has to be prepared to deal with in a kitten. Predictably, corticosteroids are your best bets for cats, but because this can be lifelong, it is very reasonable to attempt to move to non-corticosteroid therapy when they're in remission. Cyclosporin can be used at the on-label dose and the on-label frequency for this condition. And then if that fails, we do consider off-label species, off-label use of oclacitinib with owner-informed consent. Another kitten special is Cutaneous asthenia, or Ehlers-Danlos-like. Has y'all ever seen one of these kitties, the stretchy cats? A few stretchy cats? So these kittens usually come with a history of, I got this cat, just like we seem to do in Texas often, from like the trash can or an alleyway. That's where I actually got my most recent cat myself. And he had a bunch of wounds at the time. And you're like, okay, well, the cat came from outdoors. You gave him some antibiotics, you treated the wounds, you neutered them, you sent them home. The client comes back in like 4 to 6 weeks later and says, I left him at home while I was at work and I don't know what he did, but he's got this big wound like on the side of his chest. And you're like, that's weird. Maybe he got like stuck on like the corner of your blinds or something. Like, I guess, who knows, right? And then this keeps happening. The cat keeps wounding itself, but the cat keeps healing normally. What's helpful often is these cats, they may be thin at first, so you think they have extra skin just because they're underweight, but as they fill in, you should still be able to stretch their skin really high. And there's actually a hyperextensibility index to see how much you can stretch. But truthfully, if you have a cat with wounds, a baby cat, and you can stretch them like this, they likely have this. It's a genetic collagen defect where they don't have normal structural collagen, so they're prone to wounding, but they have normal wound healing. So these cats still can be appropriate pets, as long as maybe you get them one of those cute Surgeon suits or shirts to wear so they can't hurt themselves as often, and consider little kitty cat caps so when they do normal grooming behavior, they're not cutting holes in their skin. So I definitely have clients that manage these as just regular pets, but some of them concurrently will have excessively lax joints, just like in the human form of this condition, and may also have ocular abnormalities. The last one that I'll end on is idiopathic facial dermatitis of Persian cats, because the name is funny, and the colloquial name for this is called dirty face. So if you have any Persian breeders as your clients, they tell you that they now have a Persian that has dirty face, this is what they're talking about. It is a condition where there is just a really thick buildup of crusts and scabs on what is their minimal nose fold that exists and around their eyes. And it's a really frustrating condition to treat because it appears to be genetic with maybe a hint of an inflammatory aspect, where corticosteroids and cyclosporins sometimes help, but you're often managing them with chronic wiping away of the extra debris and chronically managing infections. So if you do have a Persian breeder that has a cat with dirty face that's severe, I would suggest not breeding it because we do see it perpetuate in future generations. So really, key points for this one. Infectious things, parasitic things, and allergy is going to be common across puppies and kittens that you'll see every day. Using ectoparasite trials and checking for infectious disease is the best way to go, and will probably remove like 95% of your skin issues in babes. But if you have something that looks unusual, remembering breed predisposition can help. You know that Persian cats get dirty face and subcutaneous ringworm. We know that golden retrievers get ichthyosis. So with that kind of in mind, you can kind of narrow your focus when you're encountering something that's a bit more unusual. And don't ever be afraid. If it is weird looking or weird to you, it is always okay to recommend a diagnostic for a definitive diagnosis because you're going to get a lot of information that way. So biopsy away. Any questions? Thanks, friends. Here's the QR code again.
All right, we'll give these ladies just a couple minutes to set up, and then we'll have about a 25-minute Q&A for you guys. Again, the code's up there if you want to submit a question. Okay, so let's see. First question for Dr. Upchurch. What is your opinion of using wet versus dry swabs for samples?
It depends. If it is already a moist lesion, I don't worry about making it wet. If it is a little drier, you can try moistening it or just switch up to tape. You might get a better luck with tape for the drier lesions.
Okay. For Dr. Gentry, on your slide that showed the fungal arthrospores, how were you able to stain the hairs from a plucked sample?
Yeah, so when you're looking for spores, you don't always, that's the picture that you saw with the neutrophils, that was just actually like an impression with a slide. So if the ringworm is draining, like the carrions will, or even for cats that have a crust, you're just pushing the slide on there to see them. When I'm doing trichograms, you can stain them, but I often don't. If you just lower your condenser and look on 10 and then maybe 40x, you can see the spores without having to stain.
And I misspoke a little earlier on my slide when I had the stain slide. That was a tape prep that had been done on that sample and then been stained.
Okay. Dr. Upchurch, do you have any recommendations for stain jar management?
Ooh. So our nurses like to get our jars cleaned out about once a week. And we also have 2 sets of jars. So we have a dirty set and a clean set. So everything that we do on a daily basis, ears, fecals, things like that, go in the dirty jar. And then our FNAs and our blood smears go in the clean jars. So we kind of separate it out like that to try and keep cross-contamination to a minimum. But at least once a week to dump it out, wipe out your jars, clean them out, and put fresh in. If you're not doing as much, you might be able to stretch it out another week, but at least once every 1 to 2 weeks, change it out so you're not getting contamination in there.
Okay, thank you. Dr. Gentry, what is your experience with sensitive stomach German Shepherds and interrelated skin allergies, primarily your recommendations for clients?
Yeah, so I think for German Shepherds, right, they're prone to a whole host of inflammatory diseases, right? Not only are they allergic, but they may have inflammatory bowel disease of varying types. And I'm not an internist, so I'm not going to get into the bowel part of things. But sometimes we get lucky, right, that their itch and some of their bowel disease can be both controlled with diet. But I don't want you to get discouraged if you find that the skin is better with the diet, but they're still having diarrhea. Or their diarrhea gets better and they're still really itchy, because they still may have inflammatory bowel disease that's food triggered, but have completely environmental allergy skin disease, or have a different German Shepherd bowel disease and food responsive skin triggers. So I think you just have to treat them knowing that there could be overlap, but it's also very possible at the end of the day you will have 2 completely different management strategies for those conditions.
Okay. Dr. Upchurch, do you recommend any sort of site prep before taking a skin lesion culture to reduce overgrowth of commensal organisms?
I wouldn't necessarily clean it because you want what's on there. If you're trying to get that deeper debris, I'd probably do just a surface wipe with a piece of gauze if you're trying to get that draining tract material. But otherwise, no, I would really get in there. Dr. Gentry, do you have anything to add on that?
Yeah, I think if you're dealing with nodular skin disease, particularly closed nodules, it's okay to prep the surface, right? So I'll prep it with chlorhexidine, but then I will use sterile saline to rinse off the chlorhexidine. Because what you don't want to happen is there being residual chlorhexidine. You take your biopsy sample, you send it out for culture, and the chlorhexidine in there actually inactivates what you're trying to get. So if they're closed nodules, it's okay to clean the surface, sterilely prep it, but then you need to rinse it off. We also know that it's seen more, I think, in human medicine, but in animals we wonder about too, that lidocaine can also inactivate growth of organisms. So if you're going to biopsy a nodule that you're like, okay, this is paniculitis, is it sterile versus infectious? And I want to send out all the tests, cultures, and a biopsy. You want to make sure that your lidocaine goes around the edge of the lesion, not directly underneath, because that could potentially inactivate your sample.
Okay. Dr. Upchurch, on your slide that showed the fungal arthrospores, how were you able to stain? Oh, I already asked this, didn't I? Mm-hmm. Staining the fungal. Never mind. Last question for Dr. Gentry that I have on here. Would you pre-treat prior to future rabies vaccination, if a history of rabies vasculitis, and also, I guess, follow up to that is, has anybody evaluated if changing the manufacturer of the rabies vaccine would affect giving a rabies vaccine? Do we know if it's the vaccine rabies itself or those other adjuvants in the
Yeah,
vaccine?
so we think it's typically adjuvant driven, but there's no literature to say that if you switch brands, it would be any better or worse. So like, is that worth a try? Sure, because you may have to vaccinate them again, but I would just plan for having the same issue. And because it is a late phase reaction done by lymphocytes, you can't pre-treat for it. Like you can't give it a diphenhydramine or even corticosteroids right after to make it not happen, because it's something that happens weeks to months down the line.
Okay, let's see. I just had some more come in here, so let me just take a quick peek. Dr. Gentry, how do you discuss Apoquel usage in cats off-label with clients, and how often do you see adverse effects?
Yeah, I think that's a good question. We have struggled with this since Apoquel came out now a decade ago. So the way that I practice my paralytic cats or allergic cats is I'm still going through, are they on a good ectoparasite prevention? Do I know they failed a food trial? If they're non-seasonal, if they're seasonal, we just move on to environmental. And I try to stick with initially cyclosporin, right? Because it's labeled for cats, and predictably cats tolerate cyclosporin well outside of GI adverse events when needed. I also actually really push allergy testing and immunotherapy in cats. Cats seem to tolerate injections weekly even better than dogs because they have a lot of scruff to give it in, and it predictably limits the amount of drugs they use. But if I have a cat that has severe GI adverse events to cyclosporin or doesn't work, they've been on too much prednisolone, and that's what your personal feeling is of too much corticosteroid use in a cat. Everyone has a different decision point for that, and I'll leave that to a personal choice. Then I do consider off-label Apoquel. But the clients need to know that it is not labeled for that species, and that the doses that we often use in cats is higher than what we use in dogs. We just started a mg per kg versus like around a half, because the half-life in cats is like 2 hours versus it's 4.5 hours-ish in dogs. So they burn through it faster. So you're going for a higher peak initially, and because they burn through it faster, it's also usually given twice a day. So everything about this is off-label. I have some cat patients where they tolerate it well. There's no GI adverse events, there's no changes in their red and white blood cell lines, and we've used it longer term. I've also had some where it's caused anemia and severe leukopenia, and then you would want to discontinue it. So it's done as a nothing else has worked kind of therapy for me, and with the understanding that the client knows it's off-label, knows that there may be adverse events, and that therefore requires increased blood work and physical exam monitoring compared to some of the other typical allergy therapies.
Okay. What dose of do you prefer for cetirizine, also to Dr. Gentry?
So for cetirizine, I typically do 2 mg per kg. There's doses anywhere from 1 to 4 mg per kg, but because hydroxyzine, which is converted to cetirizine, is 2, I just usually do 2. So for really little dogs, so if you're like a 5-kilo little toy poodle, it's nice. It's just give a Zyrtec once to twice a day, right? If it's going to help, right? Knowing that antihistamines are not terribly effective for dog allergy because they have mainly lymphocyte-driven disease, not histamine-driven disease. But for really big dogs, if you tell someone with a German Shepherd, okay, your dog's like 40 kilos, can you give 8 Zyrtec twice a day? Like, they're gonna think you're insane, right? Like, no one's gonna go for that. So that's when you just wanna have access to hydroxyzine, which comes in 10s, 25s, and 50s, because then saying give a pill and a half of a 50 twice a day seems very reasonable to a client.
Okay. Another one to you on the best way to treat ringworm if the owner, I think they're saying if either they don't use itrafungal or they cannot bathe the cat.
Yeah, so if they can't use itrafungal and there can be no bathing, then I would suggest terbinafine, right? Because it comes in a tablet, which is good that it's low cost and it's easily available and can be crushed and hidden in food. It's really not that bad tasting, so I would suggest that. And if they can't bathe the cat, you could still consider leave-on antifungal therapy. So like miconazole chlorhexidine as a mousse can be left on the skin, as well as miconazole cream. It's just that we don't want to use these topical spot-ons as definitive therapy if the cat is quite affected or there's other cats in the household, because you may not cover all the affected hairs and therefore leading to more spread.
Sorry, 1 second, just clicked out here. Regarding post-grooming folliculitis, can one take measures to lessen the likelihood of recurrence?
Yeah, that's a great question. And I appreciate you guys bringing that up. So if you've had like a German Shepherd where this has happened to them, they went to the groomer and it happened, and the owner's like, I'm not going to groom them anywhere anymore, I'm going to groom them at home, and it still happens. Usually what is happening is over-aggressive bathing styles. So the hairs are growing in one direction, right? Front to back, kind of like this. If you then rub the dog in the opposite direction and aggressively put the shampoo in their skin in the direction that's not of hair growth, you're much more likely to have this happen. So these dogs can still be wetted down. You can still have shampoos applied to them. You just must rub very gently in the direction of hair growth without any sort of brush or grooming aid.
Excellent. I love this one, says specifically from a vet student. So thank you for being here, vet student, either virtual or in person. Does the management of pemphigus foliaceus in kittens require the long-term use of steroids? And does the steroid treatment need to be lifelong? If so, how do we best manage the side effects that could result?
Yes, that's a great question. I will start by saying every animal with pemphigus is an individual. We know globally about 70% of cats and dogs that have pemphigus are what we call lifers, meaning we either lose them to follow-up or they have a disease that requires therapy continuously. That means 30% of animals seem to get over it at some point with chronic therapy use. So I'll just put that out there with kittens. I've had some that have outgrown it. I've had some where they're lifelong. You don't always have to use corticosteroids forever. So corticosteroids in cats and dogs are the most predictable drugs to get a remission of pemphigus, and then you slowly taper the dose. You may get the cat to a point that it's on 0.3 mg per kg of prednisolone every other day, and depending on the owner's finances and goals, that's a pretty low dose for a steroid-tolerant species. Yes, 5 years from now that may add up, but that's not unreasonable. But if we keep needing a higher dose, let's say a mg per kg per day for control, that's when you want to add those second agent drugs, cyclosporin ideally, and if that would fail, as we talked about, the off-label use of Apoquel to lower your steroid requirements. So anytime you diagnose an immune disease that it's going to be long-term to lifelong, you have to have that conversation up front with the client and say, we're going to use drugs long-term that may cause adverse events, but that is what is available, and we're going to try to do what we can to minimize the side effects.
Kind of another follow-up on that one, especially when on the question with the rabies vaccine. So in jurisdictions where there is not a rabies vaccine exemption, I mean, I guess at that point, yeah, fingers crossed, perhaps changing manufacturer. Yep. I guess the site of the vaccine, we don't have any reason to believe giving it at an alternative location would be a difference.
They'll just get it there instead.
They'll just get it there. Yeah. Okay. So yeah, cross your fingers.
And if you see it start to happen, you can start to treat it, right? So like if you see it happening and it's a vascular ischemic dermatopathy, we put them on pentoxifylline, we put them on short-term steroids, we transition them to Apoquel. So I've had some that have been on their drugs still and then are coming due for their next vaccine, and we go, okay, maybe it'll be less severe this time because I'm already pre-treating you. But if they resolve within a few months and now we're 3 years later giving a vaccine, I can't tell you I've got good literature to say to restart all those therapies before we'll do anything to prevent it.
Okay. That's the ones that I have on my document. Have I missed anybody in person, or does anybody want to add it in person? Yep, I see you. I'll come to you. And I'm going to hand you a microphone and you have to talk into it, so sorry, so those online people can hear you.
So my question is for Dr. Gentry. So when you have a hospitalized case of like TENS or SWEET, what are your discharge criteria for those animals?
That's a great question. So I will be frank up front and say I never manage these patients alone. Right? I have like an adult supervisor, right? That's either a criticalist or an internist or just one of the hospitalists managing them. But our discharge criteria typically is that they are willing to eat and drink on their own, unless we know they're going home with an E-tube because they have severe ulcer disease, meaning they have to have a way to get nutrition in to leave the hospital. Otherwise, they're not going to be successful. And ideally, they are no longer febrile and at risk of developing sepsis, meaning their wounds are healing over or are not as exudative enough that we're concerned that just being in the world will lead to infection. So if we're eating, drinking, not febrile, our wounds are not at risk of sepsis, and we know that we can get the immunosuppressants into the dog at home, not just by IV access, you can go home.
Thank you.
Any other questions from the room? Yes.
They're hard.
This is for Dr. Gentry as well. So you mentioned a link between pemphigus foliaceus and vaccines in kittens.
Yeah.
So they're going through their kitten series of vaccines. They develop pemphigus. What do you recommend?
I think the frustrating part is we don't know always who's idiopathic and who's vaccine induced, right? So we see it in kittens and we say, well, it's a time since your last vaccine. But the truth is, because we don't have a control population where we just wouldn't have vaccinated those cats, you can never prove it unless they go into a complete remission and then they reflare after that when they get their adult vaccines. So often if I have a concern that either a vascular skin disease, so the ischemic dermatopathies, or pemphigus is triggered by a vaccine, and we treat them and they improve and are on minimal therapy by the time they're due for their next set of vaccines, I typically spread them out because I don't know whose fault it was. If you are playing the odds, rabies has been implicated more, but it's not the only one that may trigger it in a specific patient. Or it could have actually ended up being that it was just idiopathic around the time of vaccines. So you individualize their vaccines usually by 2 or 3 months apart, because ischemic dermatopathies will take time to show up versus pemphigus happens pretty fast. And then you see what happens. And I know that, and frankly, to my knowledge, and y'all can tell me if you found anything on this, there's no good literature about how we actually go about reintroducing the vaccines.
Other questions? One that I've always wondered is on those microsporum canis patients, so their hair is going to fluoresce until it falls out, right? So how long you just, like your topical treatment to reduce environmental contamination, are you just treating topically until you have the 2 negative fungal cultures and then you know the hair's still going to glow until it falls out, but it's not contagious, or how do you address that?
Yeah, so that's a great question. So it glows because the ringworm is actively living in the hair, right? Starting from midway down, like so below where we can see, to the tip. So as you begin treatment, the glowing hair starts to grow out in a sense. So they can be DTM negative and still have the top 10 or 30% of the hair still glowing. So if I had a glowing pet and clients were more financially limited, so they had 3 kittens and we could not afford follow-up DTMs, right? Then watching until all the hair is no longer glowing and the pet has no other signs of alopecia, and it's been more than 8 to 9 weeks of therapy, which is how long it takes for most cats to be clinically and mycologically cured, I'm okay with that. But usually, yes, you continue treatment until most of the hair is no longer glowing, because by the time it hits the tip, they are not contagious anymore and they don't have active disease anymore.
Great. Okay, any other questions? All right, I have to look at my schedule to see what our lunch break looks like here. All right, it looks like we've got our lunch break from 12 until 1, and then session 4 will begin at 1 p.m. So have a nice lunch, everyone.
Thanks, guys.
All right. I hope everybody had a nice lunch. Ready to get started this afternoon. We're honored to have Dr. Sellier, who is a South African and European board certified small animal internal medicine specialist and is an assistant professor here at Kansas State University's College of Vet Med. Together with her expertise in solving complex medical challenges, Dr. Sellier has a special interest in immunology and infectious disease. After 6 years in private practice and 9 years in academia, Dr. Sellier relocated from South Africa to join the faculty at Kansas State University's internal medicine department and bringing her global perspective to clinical and academic work. Her current research focuses on acute phase protein response in cats with histoplasmosis, and she's passionate about helping students become resilient and well-rounded veterinarians and can think on their feet. In her spare time, she enjoys trail running, hiking, and reading. Welcome, Dr. Sellier.
Thank you, Dr. Boyer. Can everyone hear me? I have the same issues as Dr. Upchurch with my mic. So welcome everyone, thanks for staying after lunch. So I'm from South Africa, as Dr. Boyer just said. And where I'm from, we don't have veterinary dermatologists. So skin cases are either seen by the general practitioner or internal medicine. So when I came here, my biggest joy was to find out that I don't have to see skin cases anymore. So, but what I do like about skin cases is what they can tell you about what's going on inside. And it's a neat little trick once you once you do get experience, like most of you are with these skin cases, what you can tell about an animal just by looking at the skin. So when we get cases in, the first thing I like to do is actually just stand there and not do anything. And the standing there part is actually just to look at the animal. So to see how they move, how they interact, what their mentation is like, but then also specifically muscle condition and what the skin looks like. Because the skin tells you a lot about how the dog's general health actually is. And the same with cats. You can get owners that come in with their cats and they say that the cat is just not feeling well since yesterday or the day before. But when you look at the cat, and you've all seen these guys, the cat has been is scruffy, it's ungroomed, it's got this oily coat, and that tells you that this animal's actually been sicker for much longer than what the owner is aware. And like we all know, cats really like to hide things until they basically at the point of dying. So the skin tells you a lot of things. So even though I don't really like to do skin, it is very helpful for my part of my job description. So it can be really obvious. So, and you all know these cases that walk in the door. This is supposed to be a Pomeranian. And they come in with bilateral symmetrical alopecia, and without really doing too much more, you know this is going to be endocrine skin. Or it can be like this case, which is a mature golden retriever, where the owner came in for a workup of poor weight loss, and the dog doesn't want to go on walks anymore, and it lies around the whole time. And when you look at it, the dog has got this really sad, sleepy expression, which we also call the tragic expression. So just by looking at it, you can already think this is probably going to be a hyperthyroid case. So it can be really very easy in some cases, but this talk is not going to be about the easy cases. Okay, so where's the fun in that? So then you can get these guys in. So this is a 3.5-year-old male cat, came in for vaccinations. And part of your physical exam, you feel the little paw pads, the toe beans. And they're really squishy. They are pillowy and squishy, and they don't feel like a normal paw pad. But the cat is otherwise fine. But you do notice on your records that since last year's vaccination visit, the cat has lost a bit of weight. So what do you do with this information? The other one is you have a dog that comes in with a complaint that he's suddenly lame, and the lameness is progressive. And when you look at the paw pads, it looks like this. It's got hyperkeratosis, there's some fissures in those paw pads, and the dog is really painful on it. So what does this mean? And this is what we're going to talk about today. So the skin is really important in raising your diagnostic suspicion that there might be some underlying condition. And the thing about skin is that it's sometimes either the first indicator that something is going on or the only indicator. So if you miss that little clue, it's going to either prolong your diagnostic process, or you're going to miss important diagnosis early on in the process where you can still do something about that condition. And it helps you to direct your differentialist. And I'm not talking again about the cases that come in, which is a pyoderma or allergic dermatitis. These are the cases where your spidey senses are tingling a little bit, and where you realize this is not quite reading the textbook. So red flags, and it's the same as what Dr. Upchurch and Gendry said, is with most skin cases, they feel well. They're still eating, they're still active. But if you have a patient that comes in that's not feeling well, they've not been eating well, they've been losing weight, they might have some lymphadenopathy, and when you do your workups, you see there's cytopenias or anemia, especially chronic non-regenerative anemia. It's a very good indicator of underlying disease. Gastrointestinal signs, for example. And especially if it's a case that suddenly has these skin lesions. So it's very different when you have a patient present who always had skin lesions, and this has been a long-term process, because then usually the skin is something that's an additional problem. But if you have a patient that comes in and it's not well, and you've got new onset of skin lesions, and especially if they have a recent travel history, that should be another red flag for you that something else is going on. So, for example, this case is a Labrador that we saw actually fairly recently on medicine. And of course, the last few weeks, I've literally been taking pictures of every single skin I could find. So I took pictures of this dog because the dog presented for a workup of chronic intermittent vomiting. So it's a GI workup. And most cases, if the patient is still eating, and they haven't lost any weight and they're still active, otherwise fine, the first part of a GI workup, and especially depending on owner finances, would just be to start a deworming trial and then also put them on a novel or hyperallergenic diet. And that is your starting point. This dog, though, if you look carefully, there's some muscle loss and it's starting around the face. And very often with these chronic conditions, if they do start losing muscle, it will be around the masticatory muscle. So that's a big clue that something else is going on, especially with a dog that is actually still eating and just vomiting intermittently. And if you look closely, this dog's coat was really dull, and it was coarse and flaky, and the dog shed a lot of hair. So this tells you that even though it's a chronic intermittent GI problem, this is not the kind of dog that you just send out the door with a different diet. This dog probably will need some blood work and an abdominal ultrasound because something else is going on with this dog. So when we look at skin cases and systemic underlying causes, there's a few ways in which you can approach this. So you can either classify it pathophysiologically, and this is according to endocrine conditions that does it, immune-mediated conditions, paraneoplastic, metabolic such as liver, kidney, or nutritional causes. And that is fine. And when you read a lot of your reference textbooks, they will divide it into these categories. And these really help if you have a typical history of what could cause it, or a very typical presentation like our little toy pom, because then you can immediately say which category it will fall into. For me, and especially because I'm not that great with skins, or I don't really want to be that great with skins, I like to do pattern recognition. So I want to actually look at the skin, and based on what the skin looks like, divide it into separate categories, because I'm a medicine person, so I like to categorize things. So put it in a category, and then according to that visual change, have my list of differentials that would do that. And here again, I'm not looking at those cases that come in with an obvious cause. I'm looking at those cases where I can use the skin to help me get to a diagnosis quicker. Or for those cases where I know this is a rare condition, so if I don't recognize these first signs, these subtle signs, I will likely miss the diagnosis. So this is specifically for those cases where you don't immediately go and say, it's likely going to be this. Then I like to use pattern recognition. So I divide the skin changes according to visual changes, because like I said, the first thing I do is I look at the animal. And it seems really silly, but the first one would be a color change, and that could be red, yellow, black, purple, whatever color you can think of. You can get different colors. And then alopecia is the other differential that I would look at, or the change in the skin. Thin or fragile skin, and then also thick skin, if there's any scaling or crusting, and any nodules or plaques. And these are the general categories. When I look at the patient, I say, okay, does it fall in one of these? What is my more likely differentials for these categories? And sometimes they can overlap a little bit, and you need to see where your predominant pattern is from. But generally, it makes it a little bit easier. So if I look at color change, so if you get this cat in as a 10-year-old domestic short hair, presented with acute onset lameness and pain, when you look at the little feet, you can notice that one paw pad is still a nice light pink yellow color. The other one is more purple color. So there's a lot of things that will cause purple color discolorations, but in a cat with this presentation, I'm going to narrow my workup immediately into a thromboembolic problem, because that's the most likely thing that will give me this combination of signs, and the color change is what clues you into that. The same with this guy. Okay, so we can all see that's a yellow skin. So have a 3-year-old female spayed terrier cross that presented with syncopal episodes, lethargy, and anorexia, and it's got an ectric skin. So when I look at patients with ectric skins, you can divide it into 3 categories. So pre-hepatic, hepatic, or post-hepatic ectris. So I look at what the underlying skin tone is. So do I have a yellow skin on pale, so yellow on white, or do I have a yellow on pink? So if I have a patient that's yellow on pink, so pink skin underneath, I know it's likely going to be hepatic or post-hepatic. Then I already narrowed down my differentials. If it's a dog that comes in with yellow on pale, then I'm going to look at something like a hemolytic process, so IMHA, for example, for a pre-hepatic cause. And if you combine that with the rest of the history, it really helps you to hone in your workup immediately and change the order of your differentials. So this was an IMHA patient. I once had an owner and a dog present with orange skin, which is where the other colors come in. So don't get confused with people that eat a lot of carrots. They change orange. So you sometimes do get these different pigments that come through as well. The other case would be a 5-year-old female spayed Labrador that presented collapsed red mucous membranes. So generalized hyperemia, and you need to think about what will cause that kind of presentation in a collapsed animal, and you need to think about your differentials fairly quickly. So in this case, you need to think about something like heat stroke, mastocytosis, so mast cell disease, and especially systemic mast cell disease. Sepsis will do this, ethanol intoxication, and interestingly enough, Addison's disease will also do it. So patients with Addison's disease can come in with pale mucous membranes because of hypovolemia, but they can come in with these really hyperemic mucous membranes and hyperemic skin, which is something that I only learned fairly recently. And the reason for this is that with cortisol, or with blood vessel vasoconstriction, you actually need cortisol for your adrenaline, your catecholamines, to be able to work on those little receptors to cause vasoconstriction. So some of your Addisonian patients will come in collapse looking like this. And if they don't have a history of heat stroke or ethanol intoxication or sepsis overtly, then Addison should be on your differential list for those cases. Another condition that is not on here is also again a case that I saw recently. It's a Labrador that was in a house fire, and that dog had carbon monoxide toxicity, and that dog came in with mucous membranes like this. So the color gives you a clue and specific differentials of what could have happened to that collapsed patient. It saves you some time and gets you to an answer quicker, to get to the correct treatment quicker as well. So with alopecia, one of the weird and wonderful cases are feline paraneoplastic syndromes. So these cats, so this is really very rare. We do sometimes see them, but I think I've seen one in my career so far. And I asked some of our other internists, and they also have seen one or two of these cases. And they are shiny cats. So acute onset alopecia, it usually starts periocularly, and it then distributes to the rest of the skin, especially the ventral abdomen. And these cats really are shiny, so you won't miss these changes. The skin is not fragile, but the hair does epilate easily. And it's symmetrical and is non-pruritic. And the interesting thing about this is that the skin will start changing like this before you actually have a cat that shows signs of illness. And the most common thing that we would see this with is pancreatic neoplasia, so carcinomas or bile duct carcinomas. And if you do start seeing these changes, the first thing you do need to do is go do an abdominal ultrasound and see what is going on there. It can also be subtle. So if you think about our endocrine disorders, we all think about the typical Cushing's patients that walk in, but it can be really subtle as well. So in this patient with suspected hypothyroidism, this golden retriever didn't have any overt signs of alopecia or hyperkeratosis that we could see. But when we moved the dog's collar, you can actually see the areas where there's friction. The dog has started losing hair. And that was the only subtle change that we did have with this dog. And when we actually tested him for hypothyroidism, he actually had a total T4 of 0, which I don't think I've ever seen, and a TSH of 1.5. So this dog basically read the textbook. But if you don't see those subtle changes, you might miss this diagnosis initially. The other condition that is also fairly rare, but I think we're going to see more of these cases, are skin fragility syndrome. So this is one of those horrible conditions where cats come in with these tears. I don't know who of you've seen these cats come in. Yeah, they are horrible. You can't handle them, you can't pick them up, you can't restrain them. The moment you touch them, the skin just tears open. They can't groom themselves. As they groom themselves, the skin tear. The skin will tear spontaneously as well. So a horrible condition. And these cats come in with scars all over from healed skin tears. And usually, most of the time, it would be due to excess corticosteroids. So, and that would be either endogenous, so with hyperadrenocorticism, so that's a typical difference from cats and dogs, or with excess corticosteroids. But the interesting thing is that you can also see it with hepatic lipidosis in some cases, or hepatic neoplasia. And with FIP being FIP, you can sometimes see it with FIP cases as well. Prognosis, unfortunately, for these cats are quite poor. There's not really much you can do about it. And then by the time where they start showing these signs, usually the disease is quite advanced. And you cannot close these wounds either because the skin doesn't hold any sutures. And then with thick skin, we always think about Sharpes. They're the poster child for thick skin. But Labradors, or which are prone to hypothyroidism, or long-standing chronic hypothyroid cases that are untreated can come in with these really thick skin folds. And when they come in with the typical history, that makes the diagnosis easier. But when they come in stuporous or comatose, then that becomes a little bit more difficult. Because usually, like I said, these cases are not treated cases, so very often the owners are not aware of the diagnosis. And with a stuporous or comatose patient, you need to try and figure out what is going on with them as soon as you can. And this is a big clue, that they have these really thick facial folds, tragic facial expression. And about the only thing that will do that, and that combination of signs, would be severe hypothyroidism and a myxodermatous coma. The other condition that causes thick skin is acromegaly, so hypersomatotropism. And this is also a condition that we don't see that commonly, but it does have typical features, which you don't see in just every case or every different type of dermatological case. And that is because of an oversecretion of growth hormone, and that could be due to a pituitary tumor, but also due to excess progesterone, which causes mammary tissue to produce growth hormone as well. And these patients can come in with a variety of different clinical signs and clinical features. But one of the big ones are these really thick, excessive skin folds, really hard claws, but they can come in with big feet, big facial features, or broad facial features, widened dental spaces, and then also things like upper respiratory stridor, for example, organomegaly. But one of the first things that you will see when they walk in is the skin changes. Then with scaling and crusting, one of the big ones that we look at is hepatocutaneous disease. So again, fairly rare condition, but it's got very typical features. The other names for it is superficial necrolytic dermatitis and also necrolytic migratory erythema. And it can, in some cases, look a little bit like an immune-mediated condition. But if you do see these signs, one of the big things you can do is go for ultrasound, because these patients have a very, very typical presentation in terms of their liver. And that is, the liver changes is basically pathognomonic for this condition. And they typically have this Swiss cheese change in their liver. And the reason for this is usually really severe liver disease, or in some cases glucogonomas, so pancreatic neoplasias. And they think it's because there's an amino acid deficiency that's triggering this. The prognosis is poor for them. You can try specific dietary therapy, specific amino acid therapy, but generally the prognosis is quite poor for these guys. Changes that you will see is over the mucocutaneous junctions, pore pads, pressure points, and over the face. Another interesting condition that causes really bad scaling and crusting, which is also one of those very atypical or rare presentations, is feline phomoma associated exfoliative dermatitis. So this is characterized by really diffuse scaling and crusting and erythema. And these changes in the skin precede any of your other clinical signs. So clinical signs would be dyspnea, weight loss, coughing, or anorexia. So you will first see these changes in the skin, and they are fairly dramatic. And when you do see it, you would want to go do a chest rad, because these cats do have phymomas. And if you go and remove that phymoma or the mediastinal mass surgically, the skin resolves. But if you catch it early enough, the prognosis is a lot better. And then a new one, or it's not really a new condition, but it's something that we are more aware of, is plasma cell pseudodermatitis, so pillow foot. Who of you have seen some of these cases come in? Yeah, it's not that common that you do see them. So it only affects the foot pads in cats, and the foot pads become really like kind of swollen, squishy, pillowy, and sometimes later on it becomes scaly and crusty and ulcerated. And they think it's an immune-mediated process, because these cats do respond to immunosuppressive therapy and to doxycycline. And if you go and aspirate that foot pads, you get plasma cells. So we think it's an immune-mediated condition. But what is interesting about pododermatitis, and again is one of those conditions that you actually pick up before they become clinical, is that it's associated with protein-losing nephropathy in cats, and specifically immune complex glomerulonephritis because of chronic immune stimulation, and then you get antigen-antibody complex deposition on your glomerular membrane, and these cats go into renal failure. And it happens very quickly. And once the ball is rolling, you're not stopping it. So one of your first clues to this condition is actually just looking at those paw pads. And it does have a very typical picture for protein-losing nephropathy. It's generally male cats. They between 3 and 3.5 years old. They can be retrovirus positive or negative. But what you would also find is rhinomegaly in these cases. They typically have a non-regenerative anemia, and in some cases it can be really severe. And they also have hypoalbuminemia because of the protein loss, and hyperglobulinemia because of chronic antigen stimulation. And when you do a urine protein creatinine ratio, they typically have a severe proteinuria. So it is rapidly progressive. So if you don't catch it early on and manage it really aggressively, these cats do go into renal failure. So if there's a suspicion that you are dealing with immune complex glomerulonephritis, the main diagnostic step is actually renal biopsies. But very often these cats are too compromised to undergo renal biopsies. So if you've got that typical picture, how these cats present, and you've got a severe proteinuria, then you can actually make a presumptive diagnosis of this condition and start treating already. If it is a proteinuria and the UPC is kind of borderline, so if you have a UPC that's less than 2, that's more associated with tubular proteinuria. If it's more than 2, then you look at glomerular proteinuria, which is what we are talking about here. And if you're not sure if you're dealing with a tubular glomerular problem, we do STH page on this urine. So it needs to be fresh urine, and they do a protein gel electrophoresis, and they actually look at the amount of high molecular weight proteins within that electrophoresis, and that gives you an answer. So with these cats, if you start managing them aggressively, so they go on a renal specific diet, and then we also put them on immunosuppressive therapy, and generally you need at least 2 types to control these cats. They go on antithrombotics because they're prone to developing thromboembolic disease. And they also go on something that's like an ACE inhibitor or ACE blocker to also help with the proteinuria. And because these cats can get profoundly anemic, we start managing that anemia also early on in the disease process. Another interesting case that causes scaling and crusting is epitheliotropic T-cell lymphoma. So this is one of those diagnoses that catches you off guard because it can look like a lot of different skin conditions. So for example, this patient there looks a little bit like the other one on the left-hand side, but the patient here has got Demodex diffusely, and this one has epitheliotropic T-cell lymphoma. So if you have one of those presentations and it doesn't quite fit into a category, and you did your basic dermatological workup and nothing really is clearly indicating to a diagnosis, you want to go for biopsy sooner rather than later. These cases sometimes or very often have lymphadenopathy, and sometimes you can get spread to your other organs like the liver and spleen. But generally, you will start seeing it in the skin to start with. Then another scaling and crusting condition would be dermatomyositis. So we had 1 or 2 of these cases recently, and if it's a collie or it's a Shetland sheepdog, this should be on your radar. And it's a rare condition. It's an autosomal dominant condition. And these cases, when we see them, they typically come in because of the GI signs. So they develop megaesophagus, so they come in with dysphagia and regurgitation and weakness. And if you don't see that it has to do, or that it's coupled with what's going on in the skin and scaling and crusting, and you miss the fact that it's a collie or Shetland sheepdog, you might miss your diagnosis and then do a lot of other testing to look for the underlying cause. And there's about 23 or 24 different differentials for megaesophagus. And if you recognize this specific pattern, you will head to that diagnosis much sooner and start treatment for these patients much sooner. So systemic lupus erythematosus is a condition that is, it's one of those differentials that is basically on every differential list, because it can look like anything and it can do anything. And whenever we have a bunch of medical problems or problems on our blood work or in our history, lupus SLE is on that list, because it can do anything and it affects multiple body systems. So literally every system in the body can be affected by lupus. And it's because the condition has to do with developing autoantibodies against intracellular antigens. So it targets every single cell in the body. And you can have signs of dermatological changes, especially mucocutaneous junctions, and it's typically scaling and crusting. And you can have signs of cytopenia, so IMHA, thrombocytopenia. You can have polyarthritis with these cases. They can come in with signs of meningitis, vasculitis. And you typically, when you do have this constellation of different problems and clinical signs, we would run an ANA titer, so anti-nuclear antibody titer. And we use a combination of different criteria to say, yes, this is most likely going to be lupus. So this is a case that we actually saw fairly recently with vasculitis. So with vasculitis, and again, there's a lot of things that can do it, but if you look at the picture overall, then that narrows it down a little bit. So, and typically with vasculitis, it targets the little blood vessels, so your N-terminal blood vessels. So those going to the ears, the little paw pads, or to the tongue. And when you look at these patients, you can see that you have ischemic damage happening there. And this is a little paw pad that's got ulcerations in it, and this dog's paw pads in general all were ulcerated, and this was a typical SLE case. Infectious disease, we don't see these cases again as commonly as before, but distemper would be one case where you have almost like a nasal digit syndrome, so hyperkeratosis of the foot pads and the nasal planum. And this is largely something that we don't see that commonly, but this is a clue. So typically this would be unvaccinated dogs, they're immune compromised, they have upper respiratory signs, they can have GIT signs, also neurological signs, and they come in and their skin can look like this. So this is a clue to test for distemper. And then leishmania is also a condition we don't really see that commonly, but it is pretty much everywhere apparently now. And more than 80% of dogs will have skin lesions, and it's typically over the joints that you would see it, so over pressure points. And they can also get these hyperkeratotic lesions on the paw pads and on the nose. And generally these dogs are systemically ill. Calcinosis cutis, so if we move on to plaques and nodules. So again, something we don't see that commonly, but it's usually, when you feel the skin, it's really hard plaques that sits on the skin. It's crusty, it can crack open, sometimes can get secondarily infected. And it's typically on the dorsal surface or in the inguinal region where we do see it. And can be due to metastatic calcification. So that is when there's increased amounts of calcium or phosphorus in the circulation. And that is what you would see with fungal disease or sometimes with chronic kidney disease. But it can also happen due to dystrophic calcification. So if there's damage or collagen changes, and you get that calcium deposition with Cushing's disease, or also with inflammatory conditions. And specifically leptospirosis is one of those conditions that can do it because of collagen damage. So if you see one of these patients come in and it's not due to cortisol, you need to check calcium levels, and you need to check for infectious or inflammatory conditions that does this. Other infectious conditions, especially where we practice, fungal is quite big. So cryptococcus, histoplasmosis, sporotrichosis, those are typical things that you do need to recognize as draining nodules, and at least do a cytology, because sometimes on the cytology alone you can get to your diagnosis, or do specific fungal testing. We recently had a cat in dentistry that had this chronic nasal discharge. And you would think that with crypto it's very typical, because we've all seen the pictures with the nose and it's got this pink thing sitting on the nose. And this cat had none of that. And it just had chronic nasal discharge, and it had a small little fluctuant pocket beneath its eye, and also not an area where a tooth root abscess would be. So right underneath the eye. And it was referred to the dentistry section for its teeth, because they thought it was its teeth that were the problem. And we eventually, everyone came, we had surgeons there, we had radiologists there, we had medicine there, all looking at this tiny little thing and the cat's nose. And we made a smear of the nasal discharge, there was nothing there. And then we decided to poke this little thing, and all this pus came draining out. And when we made a smear of that, that is actually the photo that I took from the cytology. We found crypto, and this cat has been walking around with this for weeks. So it's worthwhile when you do have these funny little nodules or pockets, just to go do cytology on it. Another weird one, which is also rare, is nodular dermatofibrosis. So that is something that German Shepherds and related breeds get. And again, it's something that it's a genetic disease, but it is something where you will see the skin changes before there's any other changes visible or detectable. So it's associated with renal cyst adenocarcinomas. So if you do see these changes, and it's typically on the thigh areas, you do need to go look and see what the kidneys are doing. Do an ultrasound, see if there's any masses there. Unfortunately, this condition also has a poor prognosis, because even with a nephrectomy, that doesn't solve the problem, because usually it will be bilateral eventually. But recognition is key in these cases. So take-home points from here is that even if you don't like skins or you're not comfortable with dermatological cases, it actually really provides a lot of insight into what is going on with your patient. It's a neat party trick when you do look at a patient and already say, well, you think there is something wrong or this is wrong with your patient. It saves you time and money to get to a diagnosis. And sometimes that would really be the only indicator that there is disease present. And it's an early warning sign. So it's important to not just realize or recognize the more common conditions, but to also look at these uncommon conditions, because they are red flags for something that requires specific testing or an earlier diagnosis to get a better outcome. So pattern recognition works quite well in this case, and I like to use color changes or changes in skin thickness, thinning of skin, fragility of skin, alopecia, scaling and crusting, nodules and plaques, and divide them into those categories to make my list of differentials. Okay, and then any questions that you have for me at this time? Okay, thank you.
We got finished just a few minutes early. Why don't we kind of bump things up about 10 minutes and take that break for 30 minutes and then try to get started at about 2:10? Does that sound good? Yeah? All right. sticking with us for our final lecture this afternoon. We want to welcome Dr. Devin Ueda, who is a small animal veterinarian dedicated to maximizing patient well-being through therapeutic nutrition, a tool that she believes offers one of the most significant opportunities to transform patient health. As a residency-trained clinician in nutrition from the University of Minnesota, Dr. Ueda developed clinical expertise in managing complex nutritional cases, holding a specialized interest in gastrointestinal disease, early renal insufficiency, and weight loss strategies. Now serving as an academic affairs manager at Hill's Pet Nutrition, she combines her clinical expertise with a passion for education. Dr. Ueda is committed to empowering veterinary professionals from students to seasoned practitioners by sharing evidence-based nutritional insights that directly improve clinical outcomes. She firmly believes that therapeutic nutrition is one of the most powerful tools in patient care. Again, welcome, Dr. Ueda.
Apparently I'm dropping my microphone, so we're just starting that off with that. Again, my name is Dr. Devin Ueda, and I just finished up a residency in clinical nutrition at the University of Minnesota, and nutrition is one of my passions in life. During my residency, I kind of got those toughest of the tough nutritional-based dermatology cases, and I often found myself co-managing cases with our dermatology service to the point where they joked that I should do a second residency in dermatology, and I laughed and said I'm never doing another residency ever again in my life. But thank you, I guess. And then I also have that unique perspective of clientele in that my dog right here, the cute little Cocker Spaniel, like all Cocker Spaniels, has atopy, right? So I get to be that owner at home managing her dermatological disease as well. So I get to do that like once a week bath and twice daily topical management. So I also understand that from the client perspective too. And so today, really, when I was putting together this talk, I thought to myself, what are going to be the most key things for nutrition and skin disease? And so the first thing that I want to talk about is really the nutritionist lens, how I approach cases in a systematic way, especially to dermatology cases. And this is going to be like the broad scope of this talk, and everything that else I'm going to talk about is going to somehow fit under this scope. And that's going to include using AI to further your nutritional assessment, nutrients of concern for skin disease. We're going to touch on that as well. And then we're just going to implement a treatment plan as well. And so the first thing we're going to talk about is the nutritional assessment. And good nutrition, we know, enhances a pet's quality of life and is integral to optimal animal care. Appropriate feeding throughout life stages can help prevent diet-associated diseases like arthritis, obesity, secondary hyperparathyroidism, which I saw an uptick in my last year of residency, as well as management of other diseases like allergic skin disease, urinary stones, renal disease, inflammatory bowel disease, and pancreatitis. The nutritional assessment is considered to be the fifth vital assessment behind temperature, pulse, respiration, and pain as well. And it really encompasses the evaluation of the animal, including life stage, disease status, activity level, their diet, how they're fed by their owners, and any environmental factors as well. And that's really what on the left-hand side of the screen is, the circle of nutrition that is encompassing all of that as well. The nutritional assessment is recommended by WSAVA and AHA for every time a pet presents to your veterinary clinic for a consultation. And that's because each factor that influences the circle of nutrition can change over time. So we require a reassessment and possible modification throughout that pet's lifespan. And so that is comprised of diet history, which can help us learn a lot more than just what is that animal eating. It can give us insight of how our clientele relate to their dog. What do they find most important about that dog's aspect of life and quality of life? It also encompasses the physical exam, and I also added in diagnostics because we need to understand the animal as a whole. And it also involves making those dietary recommendations as well. And that's a specific food recommendation, including amount and frequency of feeding and accounting for like treats that owners are gonna give, because they're always gonna give treats. Even when they see a board nutritionist, they're always gonna give treats. And a really important part of that dietary recommendation is our client communication as well. It's about educating those clients and our rapport with those clients so that we can achieve our desired outcomes of what we want that dietary recommendation to make. And it engages those clients in the decision-making process, defines expectations of what we're expecting to see with that dietary change, and we can modify our recommendations if a client says, I can't do that, I don't have the time, or I don't have the money, or it doesn't fit with my lifestyle, those kind of limitations as well. So the first step of that nutritional assessment is really going to be talking about the diet history. And this is a key piece of that nutritional assessment. And quite frankly, as a nutritionist, I found this was the hardest thing that I did on a day-to-day basis. And that's because I found that to get a really thorough diet history, I had to really ask clients a lot of questions. And more importantly, I had to most of the time try to figure out ways to ask them questions so they could give me the best diet history possible. And there's a couple of ways we can obtain that diet history. The first way, which is forms, are stuff that you don't have to have them do in the clinic. This could be before they even present to your client, to your clinic for their exam. You send out like a Google sheet beforehand and have them fill it out so that when they're checked in by your receptionist, by your technicians, they already have this so they can ask clarifying questions. And the second part is those interview questions. And really it's the opportunity for you as the clinician to ask clarifying questions and investigate even further potential sources that maybe they left off that diet history form. Or things, objects that the owner might not view as food. Like sometimes people don't think things like dental sticks or the scraps that they give them off their plate would count as food on that dietary history form. And so both of these together can give you a lot of information, but ultimately I tended to learn more when I did interviews. And so really when we're obtaining a diet history, there are areas where inaccuracies can occur. And so the first one is that we know, based on multiple studies, that there's underreporting and overreporting of foods. So the first study was performed in 2010 by Dr. German and his research group at Royal Canin, actually. And what they did was they had 14 employees in a lab environment measure out 6 different types of kibbles. And they found that even when the person was measuring the same kibble, when they were using volume measurements, so when I say volume measurements, I mean like cups, teaspoons, tablespoons, that they would either underestimate or overestimate the amount of food that they were feeding. And it could be anywhere from 18% underestimation to about 80% overestimation. And there was no really specific factors like who the person was, how they gathered the food that was associated with that imprecision. And then to take it out of the laboratory setting, Dr. Coe and his research group did a study in 2019, and they surveyed about 100 owners, and they asked them to measure different volume measurements of using one of 3 randomly assigned measurement devices. And they found that the inaccuracy of owners ranged from anywhere from 43% underestimation to about 152% overestimation. And the majority of those owners tended to overestimate the volumes of food being measured. And this, of course, poses an increased risk of weight gain and obesity because we're providing them with excess calories. And so both of these studies really highlight that even using volume measurements can be inaccurate, and really we should be encouraging clientele to weigh out their pet food because that's going to be the most consistent. And it's not just commercial diets, kibble diets we're talking about. In 2022, Grace Boothby, who was a veterinary student at the University of Georgia, and then I got to work with her as an intern last year. She and the Georgia group did run a study, and they found that there was reduced accuracy when people were putting together homemade diets when they were using those volume measurements as well. And really, in order for that home-cooked diet to be accurate, they needed to weigh out those ingredients as well. And so it's not just under-reporting and over-reporting of foods that can lead to inaccuracies of diet history, but also how we ask those questions. And so in 2015, McMartin and his research group performed an observational study. They looked at 284 video taped veterinary client-patient visits with 17 veterinarians. They found that nutrition was discussed in about 60% of those visits, and that 99 of those visits, it was like a veterinarian-initiated question-answer sequence about nutrition history. And they asked a lot of single, closed-ended questions, and really what the responses back to them were limited to essentially a brand type or a subtype, like if it was kitten or puppy or adult food, or the brand and name and subtype of a single food item. They didn't get treats, they didn't get extras that might have been being fed. And so Dr. Koh again and his research group in 2020 looked into open formed questions. That'd be like, tell me everything that Fluffy eats throughout a day, starting first in the morning right through the end of the day. And those open-ended questions actually elicit disclosure of a significantly greater number of diet-related items than those closed-ended questions do. And so they also tried to figure out how much extra time this would add to an exam. And it was really only typically 10 to 20 seconds for those answers. So not a lot of time to your exams. And actually, when you really think about if you're asking closed-ended questions and you keep having to ask, what food do you feed? Okay, what treats do you give? Do you give any dental treats? It probably balances it out. So the bottom line is, open-ended questions can elicit more information and don't extend appointment times. And so really, let's put this into action. So this is Titan. We're gonna follow him throughout his journey throughout my talk. And he is a 2-year-old male neutered Great Pyrenees. He weighs about 100 pounds and he has a perfect body condition score, which we rarely see, right? We usually see them being overweight, but he is a great 5 out of 9. He presented to me because his owners had concerns about food allergies and that he had a selective diet. He didn't really seem to really want to eat his food, and they were concerned about that. He also has a history of having pruritus and pyoderma. Started about when he was 1.5 years old, and so far his allergies seem to be seasonal, worsening in the spring and in the fall. And so when you ask Titan's owners, what do you feed him? Well, they're only going to respond with that one brand, right? That one food, because that's his main food source. And they told me it was Purina Pro Plan Sensitive Skin and Stomach, lamb and oatmeal formula, and he got 1.5 cups daily. So when you look that up, I evaluate every brand, every food that comes through me, right? And I'm looking to make sure that that brand is reputable, that they have people who know what they're doing, who are formulating, and that they have quality control, and they're a good food to feed. Purina does fall under that, so it's like, okay, so this is appropriate diet, but when I look into that cup of food is about 528 calories per cup, and when I figure out he's getting 1.5 cups daily, he's only getting 792 calories. His RER is about 1,200 calories, and his DR, which I use because he is not very active and he's obese prone, I used a factor of 1.2. His daily energy requirements is 1,470 calories. So, oh my gosh, there's something going on here, right? Is he got one of these dogs who has like an extremely low metabolic rate, or is something else going on? And really the answer is something else is going on. When I ask his owners to walk me through their day, and my favorite way of doing that is by saying, if I'm your pet sitter and you don't want Titan to miss you, how does his day go? And they're gonna tell me, oh, we give him about 1/2 cup in the morning, then because he doesn't eat it, we give him about 4 ounces of round steak, And then we leave for the day. When we leave for the day, he gets a 6-inch braided beef bully stick. And then I come home, and like every time he goes outside or when we need training, he gets like 2 to 3 Buddy biscuits, and he gets a 1/4 cup of liver freeze-dried treats. And at night, we give him a cup with another 4 ounces of round steak because he doesn't want to eat. And then we give him a Swift bone marrow. And by the end of the time, when you actually calculate out those calories, he's getting enough to maintain his good body weight, but he's only getting 53% from a complete and balanced diet. And that's going to tell me that, he is malnutrition. He has malnutrition. He's missing vitamins and minerals for sure. Because we know if more than 10% of his daily intake comes from an incomplete and unbalanced diet, that we're going to have these nutritional deficiencies. And so it's not just like commercial diets where we're adding on too many treats that I might see some nutritional deficiencies, but also home prepared foods as well. And so in 2011, there was a study that was published in the British Journal of Nutrition that found 60% of homemade diets were lacking in essential nutrients. And when they're looking at it, they're like lacking in calcium and they're lacking in vitamin D as well. And I actually think this is too generous of a number. I think it's more than 60%, just from my clinical experience. And also there was a 2013 study performed by Jonathan Stockman, who is a veterinary nutritionist at UC Davis. And he evaluated 200 recipes from 34 different sources. So websites, veterinary textbooks, and pet care books. And he found that most of those recipes, of those 200, 92% had vague or incomplete instructions on how to put together that diet. So him as a nutritionist had to make a guess how much is actually going in. And he probably had a better scientific guess than our clientele would, but he still had to guess. He also found that a lot of them had vague feeding instructions. They didn't provide calories. And then actually 13 of the recipes had garlic or onion. So we're risking hemolytic anemia as well. And then he put the diets themselves through a software system for quantitative analysis. And he found that only 9 of those 200 diets actually provided a nutrient profile that met AFCO or NRC levels. So actually provided everything that pet needed. So that meant that 95% of those recipes resulted in at least one essential nutrient, but really 83.5% of those had multiple nutrient deficiencies. And so that's one of the things hope you get from this talk is you're going to be asked, hey doc, you know nutrition. How is my homemade recipe that I made up from the internet okay? And so the answer is there's some really quick things that you can utilize in your exam room to go, no, it's not, because no, it probably is not. But one is look for an animal protein source, a fat source that supplies essential fatty acids. So really one is linoleic acid that we're looking at, which is an omega-6, and we need something like corn oil or canola oil or walnut oil, like things like avocado oil or olive oil aren't going to supply that in the things that we need. You're also going to want a mineral and a vitamin source. I lump them together because the ones that I'm actually looking for are both together, but some people will use multiple different vitamin and mineral sources that are human. And I'm not just talking about, when I'm talking about a mineral and vitamin source, like your common ones that you're going to be supplementing on top of your diets already, right? Like those pet tabs and those things that you go and you buy. I'm talking about ones that actually are formulated to be made to go on diets to make them complete and balanced. Those other ones that aren't meant for that, they rarely have enough vitamins or minerals in it because they want to avoid toxicity. And most people have their dogs on a commercial diet, so in order to avoid toxicity, you only give like a whisper in the wind. You also want to have a fiber or a carbohydrate source, and then for cats especially, is there a taurine source in that diet. If your owners are really motivated and they want to know how can I test my actual recipe, there's only really 3 ways. One is formulation software, which really as a nutritionist I have access to, but I don't think as a general practitioner, you're really going to be purchasing those softwares. The other is laboratory analysis. So sending it off to a laboratory and having them test the food and making sure it fits in like an AFCO profile. That testing costs $2,000. So most people aren't going to be able to afford that or do that. And there's only 3 labs in the country that do that. So the other is feeding trials. And these are, again, going to be limited probably to pet food companies who are going to perform these last 2 things. Because a feeding trial, you're going to have to feed like 8 dogs that food for 6 months' time. So no one's going to be doing that with a homemade diet. So the other thing is asking them, where did they get this recipe from? Is it a reputable source? And so there's really limited reputable sources online. So obviously, if they go to a boarded veterinary nutritionist, which you can find at vetspecialist.com, absolutely their recipes are going to be balanced, right? They're going to be appropriate. And these are really good for sick or not 100% healthy animals, growing animals, and they can actually take that that diet and they can put it through their formulation software and see if it's adequate. We also have Balance It for healthy adult animals, with the caveat that you really need to tell your clientele, if they're using Balance It, that they can't stray from that recipe. Because dietary drift happens. It happens in about 87% of people who go on a homemade diet. And so you want to make sure that that is not occurring. Because even one small change could mean that we're missing vitamins and minerals. Or the other thing is online consulting websites that hire board certified veterinary nutritionists as well. Okay, so that then leads us to our next step. And so really we're going to talk about Titan again. And we're going to talk about his physical exam and diagnostics. So again, he had a normal body condition score. His muscle mass index was 3 out of 3. He weighed 100 pounds. But on his physical exam, he has bilateral otitis externa. He has superficial pyoderma localized to his ventral abdomen and inguinal region. He has pododermatitis with staining on his paws in the exam room, and he's actively itching. So I know he's pretty affected, right? I'm seeing it in the exam room itself. And so when you ask the owners to do the pruritus visual analog scale, they point to 6.5. I did ear cytology, so he has intracellular cocci and malesthesia in both ears. On his impression smears of his feet, we're also seeing yeast and cocci, and then ventral abdomen, he's having cocci as well. So I know he has secondary infections going on with his allergies. So his owners might ask us, well, what about allergen testing? Can that help him? Can we figure out, does he have a food allergy from that? And it's really common in humans to have IgE blood tests for food allergies, or skin prick tests as well. And they're actually accurate in humans. And they also do oral food challenge tests that we don't do. So unfortunately, we have to tell them, no, none of the currently available tests, serum, saliva, or hair tests, will give us a definitive diagnosis for a food allergy. And that's because even completely healthy dogs can have positive results for different allergens. And then for saliva and hair specifically, there has been some studies where they sent out water as a sample, saliva sample, and hair from a teddy bear, so synthetic hair, to some of these companies, and they've come back with test results. But they actually blinded it, and they had it be multiple different patients from the same samples, and those multiple different patients came back with different food allergies. So we know they're not accurate at all. So really, if we're thinking food allergies, the only way to get a definitive diagnosis is to do an elimination diet trial for them. And this is Titan's first visit, and we'll talk about it, but there's reasons why I might not want to approach this as my first trial with this particular clientele. And so the next step is, okay, what is my diagnosis, right? And so the first thing I'm going to think about is, what are the typical causes of allergic skin disease in dogs? And the majority of them have atopy. Then we also have flea allergy dermatitis. And we're thinking about flea allergy dermatitis. Certain areas of the country are going to have bigger instances of flea allergy dermatitis than other. So I grew up in California. Fleas are year round. They are there constantly. This is a bigger bubble in California than it is where I now live, which is Minnesota, where during the winter it gets so cold, unless you live in an apartment complex, you're not going to see fleas, and it's actually very common for people to say stop doing flea medication during the winter time, right? So their flea allergy dermatitis is a smaller bubble. But even smaller bubble is food allergies. And so only about 10% of dogs with allergic skin disease actually have a food allergy. And so environmental triggers are going to be much more likely to be the culprit than a food allergy itself. The other thing is looking at the portrait of a food allergic dog. So most of them are generally diagnosed when they're under a year old, so about 40% of them. He was a year and a half, so teetering on, oof, am I thinking this is a food allergy or not? You have non-seasonal itchiness. He's seasonal, so he doesn't fit that. He has bilateral otitis, so he fits that. But the other thing is 10 to 15% of these dogs also have GI signs, so vomiting and diarrhea. He doesn't have any GI signs, so he's not fitting that. But certainly if he had GI signs, he'd be piquing my interest towards a food allergy more than he currently is. And I'm more suspicious that he has atopy, environmental atopy, rather than a food allergy. So now what? I've done my physical exam, I've gotten my in-house diagnostics done, and I have gotten a very thorough diet history. And so this is really where we can utilize AI to help us analyze that diet history. And so the first thing I'm going to do is I want to protect my patient privacy. And so any of the free AI that you can find online, I'm going to go on and I'm going to turn off its ability to collect my data and use it for further AI training. That way you're protecting your patient privacy, and it's not going to train that AI model, and also it's not going to share your private patient results with anybody else. And so the next step is I now have to write a prompt for that AI to give me what I want, but I actually make AI do it for me. And it may take a couple of tenths back and forth with AI until you get your prompt, but then you can just copy and paste that prompt moving forward, and you never have to do put together a prompt ever again. And so how I did this is I asked Gemini, help me create a prompt to find the protein sources in multiple pet food diets. Well, it came back to me and it told me it was going to analyze 5 different random diets and it was going to give me those. Uh-oh, that's not what I want. So then I told it, actually, what I want is I want the prompt to have the user put in a list of diets to analyze, and I only need a list of protein that animal has been exposed to. Well, it left out plant proteins, which most food allergies are animals, so that's okay, but I wanted plant proteins because I'm a nutritionist. And so I had it actually don't exclude plant proteins. And so then the next thing I did was put it into action. And so I put in Titan's diet history. Just in the background, they also gave me a couple puppy foods that Titan had eaten as a young pup, and he pretty much had the same treats the whole entire time. So AI told me exactly what different proteins were in those products by individual, but then it also gave me a really nice list. It gave me both an animal-based protein list that he'd been exposed to and a plant-based protein list. As you can see, he's seen a lot. He's seen beef and chicken, which are kind of some of the top allergens. He's seen fish meal, so fish meal can be pretty much any type of fish. So now I'm thinking, oh great, all fish, I probably can't feed him if I'm looking at a novel. He's had lamb, so that's not novel for him anymore. He's had pork as well, so again, pork's not novel. So there's not really a lot of novel options. Rabbit would be one, right? But in Minnesota, venison's not really novel because most people hunt. I don't know if that's the same here in Kansas, but it makes it so that's not a novel diet as well. But I also tested this, me versus Gemini. And so I tried to make this as simple as possible for myself. So I picked 5 diets from Hills that I knew I could easily find the ingredient list. And then I had Gemini look at those as well. It took Gemini 15 seconds. It took me 6 minutes and 13 seconds, and the first 40 seconds were searching for the first diet and its ingredient list. And it actually performed better than me because I left out fish flavoring in one of the diets because it was past the vitamins and minerals, and I had only skimmed the first half because most of the time, most protein is going to be before you see vitamins and minerals. So it actually outperformed me as well. So this can make your life in the clinic, because we're all busy, right, so much faster and easier for these cases. But there's some tips and tricks I want to give you when you're utilizing AI for this, and that's because you have to be very specific with the diet name. Or if the diet name is incorrect or non-specific, it will combine information for multiple diets, which it did to me, because I put in Hill Science Diet Adult 1 to 6 chicken and rice, which doesn't exist. And so it said, oh, that doesn't exist. So I'm going to actually use chicken and barley and the small and mini chicken meal and rice. And I'm just going to give you the average of what's in both of those. So you have to be specific. And then, of course, your diet history, even when we're putting it through AI, is only as accurate as what the owners have told you. And half the time they don't remember what they gave 6 months ago. So what's my next step? So again, I'm still in that nutritional triage. So I'm going to start thinking, what are the nutrients of concern for my skin disease? And so the first one is protein. Dogs have a pretty high requirement because it's needed for hair and skin. And hair growth itself can actually take about 30% of the daily protein intake. So when we're missing protein, we can see some changes both to the skin and to hair as well. Then we're thinking, okay, specifically amino acids, tyrosine. It is a derivative of phenylalanine as well. When it's used to make melatonin. And so when we lack that, we can see that reddened hair coat, especially if it's like a black-coated animal. Then we have zinc, which is really important in epithelialization, and 20% of the body stores of zinc are actually in the skin. So again, missing zinc, we're going to have some knockdown side effects to zinc as well. Copper, we'll see when we're missing that, we'll see hair depigmentation. Vitamin A, it's really essential for things like growth and development, retinal health, and then normal epithelialization as well. So again, when that's low, we're going to see some knockdown side effects to the skin and the hair coat as well. Vitamin E is an antioxidant, and so it's really important when we have diets with high omega fatty acid content that we have vitamin E in those diets as well. And so when we're supplementing with things like omega-3 fatty acids, we do have a higher requirement for vitamin E than, say, like a low-fat diet would have. Vitamin D is not on here, but also important for for cell differentiation as well. And then for B vitamins, really riboflavin, niacin, and biotin are really important for metabolic processes. And so when they're low, you can see knockdown side effects in the skin as well. This is just something I wanted to highlight when we're using omega-3 fatty acid supplementation, which we do quite frequently in skin disease, that we really need to be careful about what we're making our recommendations. So flaxseed is one that's very commonly used in humans, and you might see people recommending flaxseed as well because it has high omega-3, but it's really alpha-linoleic acid, and that dogs and cats aren't capable of elongating that into EPA and DHA, so it doesn't actually have the side effects that we're looking for. And then when we're using things like cod liver oil, they can be high in vitamin A and D, so they can lead to toxicities. And I also want to think about how much is actually coming from the food before I start that supplementation, because derm diets, joint diets, or like fish-based diets are going to be high in omega-3 fatty acids. And when we have too much omega-3 fatty acids, we can see GI signs, we can see impaired platelet functions. It disrupts the arachidonic acid cycle, and it can make platelets not clot appropriately. We'll also see things like delayed wound healing as well. So be mindful when you're making those recommendations that you're thinking of what that dog is intaking. Okay, so the next part is I've now thought about my nutritional assessment. I've triaged what is most important in this dog's diet to me. And now I'm thinking, okay, let's start with implementing our treatment plan. And so the first thing I'm actually going to do is I'm not going to think about nutrition. I'm going to think about prescribing medications. And those are to treat our secondary infections and provide immediate relief from the itching, right? We have this really vicious cycle where we have exposure to those antigens, it leads to inflammation, that it leads to that pruritus, and they start having, they start damaging their skin barrier, and then they get more exposure. It's just a cycle and cycle. And when they have that damaged skin barrier, it also allows for secondary skin infections, both bacterial and fungal. And so that makes it also really itchy. And so if we're not stopping this cycle, nutrition won't help this alone. So we have to give those medications to help make them feel better. But I'm not an expert, and I'm not a dermatologist, and we've had a lot of talks on that today. So I'm going to leave their medication recommendations to that. But my next is I'm going to provide a nutritional recommendation, right? And so the first thing I'm going to do is I'm going to select an appropriate diet for this dog. So that might mean just reducing the noise. Titan's getting an extreme amount of treats, and we know that he has unbalanced diet, so there's malnutrition there as well. So really with him, it might just be appropriate to say, okay, let's reduce the treats, let's get him on a diet, even an over-the-counter diet that corrects that malnutrition, and see what happens. The other thing we could talk about is, okay, maybe we just start him on a diet that's been formulated to help support skin. So that could be an over-the-counter diet, or it could be a prescription diet that's specific to skin disease, but maybe I do that as well. Or I go for the big guns and I go elimination diet and I go either a novel protein. Again, it's going to be really hard to find a novel protein for him, and a majority of our patients, to be completely honest. Or I'm going to go, okay, I can't find a novel protein, let's go with a hydrolyzed. But really, the one thing that we really should be thinking about is Titan's not just a dog with skin disease. Titan is a dog who has other things going on. And so we need to think of him as a whole patient. So think of any comorbidities he might have. His owner's already said he doesn't eat well. He has a selective appetite. So I need to address those concerns as well, or they're going to leave the appointment going, that doctor didn't listen to me at all. And so again, we could consider an elimination diet trial. In Titan's case, I'm probably not going to do that. I don't think this is achievable yet for these owners. They're giving a lot of treats, and they perceive he doesn't eat well, that he has a poor appetite, but obviously he has a great appetite. It's just a great appetite for stuff that's not healthy. And so I don't want to start them saying, you have to do an elimination diet trial with novel protein like any of our DD lines or our ZD lines, that if you're giving these foods and you add treats to, I as a clinician am going to go back, that client didn't listen to my recommendations. And as a clientele coming back and saying, doctor, your recommendations were not great because I can't follow them, right? And so that's not going to be my first step with him. I'm going to build up to the step if I need to. I'm going to gain their trust, but it's not going to be my first step for him. And so my first step for him is actually going to say, give him Derm Complete. If he gets treats on top of this, as long as it's less than, I'm going to say 5% for a therapeutic diet, but as long as it's less than 5%, it's probably going to have therapeutic skin benefits. And that's because it's been clinically tested to reduce environmental allergy signs. It can support skin healing, and also it can be used to manage dogs with food allergies. Again, I don't think he has food allergies, but in case he does, I'm covering my bases a little bit. And so really, why Derm Complete? And it's really because it has 3 key advantages. And so the first is the Histogard complex. And so that one is really there to modulate the inflammatory response in the skin. And so it's a combination of bioactives and phytonutrients that stabilize cells and decrease cytokine release to reduce signs of those environmental allergies. It also has an egg protein in it too as well that dampens the allergic skin reactions in dogs too. It's also formulated with polyphenols. So those are things like, think about peas, apples, carrots, cranberries, blueberries, beet pulp. We as humans are told to eat those because of these polyphenols in them. And they have both anti-inflammatory and antioxidant capabilities, and they have been shown to have cell stabilizing abilities, and they can also minimize release of cytokines as well. So the next thing is it's been formulated with key vitamins and minerals in mind when it comes to derm disease. And so first of all, we thought about the omega-6s in it and the omega-3s and have them in a specific ratios. So one thing is that they do have linoleic acid in it to incorporate into the lipids portion of the epidermis, so it can help strengthen the skin barrier and minimize water loss. And then omega-3s can dampen inflammatory responses and also help minimize transdermal water loss as well. And then we have things like vitamin A. So that's essential for keratinization and rebuilding damaged skin. We also have vitamin E, which is a key oxidant at the level of the skin, and that'll strengthen the skin barrier as well. It also has zinc, so again, that's important for skin, right? 20% of the body's stores are in the skin, but it's essential for biosynthesis of fatty acids, immunity, inflammatory pathways, and also metabolism of vitamin A. So they play well together. And then we have also B vitamins in here, so those are essential for cell renewal and collagen maintenance as well. And so the third thing that makes it a great product is that it has a single intact animal protein source. And so that single protein source will limit exposure to common food allergens. So that's why it can be used as a elimination diet trial, because it's just that one protein source. It's also been shown that it can help modulate the body's inflammatory response. It's been shown to be as effective as prednisone in modulating inflammatory responses, and it can decrease the duration of allergic reactions and decrease dermal wheal and flare reactions as well. And then as another side is that most dogs aren't allergic to eggs, again, why we can use them. So if you think about it, 90% of dogs with skin disease have environmental allergies. Only 10% of dogs with have food allergies. And then about 4% of that 10% of dogs with food allergies have an egg allergy. So we're looking at 0.4% of dogs with skin disease actually being allergic to egg. So it can be used in 99.6% of dogs with dermatologic disease. And we've also compared it to a leading diet from a competitor, so Royal Canin Ultimino. And we found that it demonstrated equivalent control of scratching, head shaking, sleep quality, and stool scores in dogs who were known to have food allergies. And we can also see visible healing of the skin in as little as 21 days in dogs with food allergies as well. So again, even though I'm not using it as an elimination diet trial, I'm using it because it's going to give that skin the vitamins and minerals and the nutrients it needs to heal. And so when I'm implementing my nutritional recommendations, I'm always going to give exact feeding instructions. We all have those owners who think 1 cup is equal to 1 cup for food when they're feeding it. And I'll even say it, my own parents did it to me. This is how I learned that lesson when I was an intern. Their dog developed PLE, and so I went, here, have this hydrolyzed diet. And I didn't give them feeding instructions. And then they were feeding the same 1 cup of food. They were giving that 1 cup of food twice a day like they had previously done on the other diet that they had previously been on, which had higher calorie contents. And then their dog lost weight. And then I went, uh-oh, I think I've learned my lesson. And so this is kind of how I'm gonna write those down for Titan's owners, right? So I'm gonna think about how much food is Titan getting right now. He was getting roughly 1,450 calories a day, and he's a good body condition score of 5 out of 9, so I don't wanna change his calories. He's getting the calories that are giving him the perfect weight, right? So I'm gonna think about, okay, I want 95% of his food to come from his complete and balanced diet, so I get that therapeutic benefit of that diet. So I'm gonna give him exact amounts. So I always give gram measurements. I don't always get clients to do that, but if I can, I'm going to. And then I'll give them exact cups that they're supposed to be feeding him as well. And then I'm gonna give him a treat balance. I'm going to make it very clear that if they go over that treat balance, that I'm worried my diet's not going to be effective for him. And I'm going to give them an exact amount of a treat that I would like them to give. Doesn't mean they have to, but it's the one that I would like them to give. And then I'm also going to put in my record, in my diet handout to them, that that dietary changes can be challenging, right? These are going to be clients that I kind of have to hold their hand a little bit, and that if they notice he doesn't really want to eat this food, contact me. I have different strategies to use to make that food seem more palatable. Some of it's making them feel like, telling them to be excited when they're giving that food, because dogs are social creatures and they read your cues, right? Other things is Derm Complete also has a canned version, so we can use that as a topper so that they perceive as owners that it looks more tasty, right? And then again, that excitement that they're giving their dog something special, the dog will feed off that energy and will accept that food as well. But he's an 100-pound dog. I'm not going to tell him to start feeding canned food right away because that's going to be really expensive for them. And then I'm going to have a follow-up plan. And that's going to be really, really important, right? So I don't make my dietary recommendations or dispense medications, and then I lose control of that situation. They don't come back to me. And so I'm going to want to see him for the medications I prescribed in about 2 to 4 weeks. And it's perfect time to also check in with how that diet change is going. Have you actually done the diet change? If you've done the diet change, what's his weight like? Yes, I got a really good diet history, but owners are inaccurate when they're reporting their diet history. Maybe he's actually getting more calories than they think he is. Maybe he's getting less calories. And I don't want him to gain weight or lose weight because he's a healthy weight. So really checking in about 2 to 4 weeks after making that dietary change, just to make sure that I can intervene before he becomes overweight or underweight. And then if all goes well, in 6 to 8 weeks after that initial appointment, I'm going to have them come back to evaluate exactly how his skin has responded to Derm Complete. And if he comes back and I don't see I see an insufficient response, and I really now think, oh, maybe there is an adverse food reaction, I can do a ZD elimination diet trial. And with these owners, they've already complied, hopefully, to my dietary recommendations, so it's going to be easier for them to comply to that elimination diet trial recommendation. And if there's a sufficient response after he's been on ZD for 8 to 12 weeks, then, we do have an adverse food diagnosis. And do we need to now figure out, can he just have like a novel protein? Does he need like a homemade diet? Can they just continue on ZD, which is absolutely fine, and most of my owners do. But if he comes back and he had a sufficient response to Derm Complete, then I'm just going to keep him on Derm Complete, right? And so it's really evaluating and making sure that we're following up so we know how they respond. Okay? Any questions?
Moment here to set up a Q&A session. So if you hold just for a moment, we'll get some chairs set up and we'll have a Q&A session with our afternoon speakers. virtually. It doesn't say who specified to, but it just says topical flunixin, your opinion. So I would say, Dr. Sully, do you have any thoughts on topical flunixin?
Not really.
Okay.
I don't know if our dermatologist would like to comment on it, but I don't really have an opinion on topical flunixin.
Okay. Anybody use that product? Anybody in the room have an opinion? Okay. Sorry, I can't answer that one for you. Anybody in the room have questions, though? Yes, be right to you. Thanks for getting us started.
So, Dr. Cellier, you mentioned something about when cats have the pillow paws, the pododermatitis, that it usually means that they may or may not have like renal disease. Is that something that's for sure something that you expect for them to have, or is that something you that if they don't have it at that moment that you need to monitor for in the future?
Yeah, so thank you for the question. So the question was, if we do see these cats with pillow feet or pododermatitis, and they don't have renal disease at that point, will they definitely develop it? Is it always associated? So generally within that age category, if you do see a cat with pododermatitis, I would definitely go and check their kidneys and make sure you do your analysis in a UPC to check for proteinuria. Because the main problem with immune complex glomerulonephritis is because you have chronic immune stimulation, and that is with the pododermatitis, it's an immune-mediated condition. And some cats, it will cause deposition of those complexes within your glomerular membrane, and that will lead to the proteinuria that you get. So even if they don't have it at that point, if it gets left untreated, there is a chance that the cats will develop immune-mediated glomerulonephritis later on down the line. So it's not always that the two have to go hand in hand, but it is a predisposing risk factor for protein-losing nephropathy.
Anyone else? Yes, thank you.
So I want to see if you can help us make this real practical. You know, how can we develop that AI algorithm like you have? And, you know, what's the quick down and dirty way that we can, you know, calculate those energy requirements, you know, then put in the diet that we want and have it spit out? I know we can do it, but it's math. And we want, if we're going to use it, we want it practical and easy.
Yeah, obviously. I do too. I will say that, so my faculty mentor at University of Minnesota is very passionate about the Pet Nutrition Alliance, and they actually have like a calorie calculator already out there. So first of all, not breaking the wheel. You don't need to use AI to do that. There's already one where you input the patient's weight. You can, I believe you can input like body condition score, and it'll give you a number. So I would always use those to my advantage. Obviously, I do quick calculations on my cell phone when I'm in the clinic room because that's what I'm used to doing, but not everyone is, you know, very quick with making that math. And then the other thing is implementing the AI as well, part of your question. And so with that, again, I honestly choose what AI system I like the best. That's how I ended up doing it. And when I was in practice, I actually used ChatGPT a lot. Now that I work for Hills, I use Gemini when I'm looking into that because they pay for a professional version of Gemini. But you pick the one you like, and then again, use AI to your advantage, help it like make your life easier. And so when I'm putting in those prompts, I actually have it write the best prompt. And that was on the advice of actually somebody who works for Hills as well, because when you're trying to write those prompts, you're going to be missing certain key aspects. And so if you can prompt AI to write it, it's going to write it for you. And again, I only have to do that once, and then I can continue to just copy and paste and like make it specifically for that particular client. And you can make it so that it will pull different things for those diets, so it can pull calories for you and stuff like that. I also do know that Balance It is coming out with like a tool online where it actually searches diets for you. So that's another one that you can utilize and use that I know is available, and it's probably simpler than making your own AI prompt.
Okay, additional questions? All right. Dr. Cilia, Dr. Ueda, thank you so much for joining us. Have a safe travel home, everyone, and thank you for being here with us.